If it is there, then it is your observation, clinical observation is very good. Okay, that's fine. Okay.
Special test. Trendelenburg test is positive. Telescope is negative. Sir.
Okay, can you just demonstrate?
Okay. नीचे आ जाइए.
Here, fine.
आप नीचे आ सकते हो.
Yes.
Yes. इस तरफ आ जाओ.
Right.
Yes. Sir.
Yeah. So that is right. So that they lost.
Getting the patient. Sir, I'll do it on the normal side first. बेटा इस पैर पे खड़े हो. Sir, both the posterior superior iliac spines are at the same level when he's standing on the normal side. So, इस पैर पे खड़े हो जाओ. When he stands on the affected limb, the pelvis on the opposite side sags, and there's a shift of the trunk towards the.
It's positive.
Okay.
Gait is bipedal biphasic unassisted Trendelenburg gait. चल के दिखा.
Is it a short limb gait? How do you say it's a short limb gait?
You said short limb?
Trendelenburg, sir.
But is there a short limb?
Why do you say this is Trendelenburg? Why it is not short limb? Sir says it is short limb.
So the pelvis is sagging to the normal side.
Where do you see?
In a
The
short
gluteal fold or?
posterior superior iliac. I marked it.
चल के दिखाओ.
If the shoulder droops on the other side, that's short limb, right?
Yes, sir.
Do you think the shoulder is drooping?
एक बार चल के दिखा.
Yeah, there is a
Little bit component is there, but it's only 2 centimeters. So he's able to adapt. It's not very obvious.
Okay.
So these are very subtle. He doesn't have that much of the adduction is restricted and the pain is not there, and he doesn't have antalgia component. So the amount of tilting is not that much. He's not compensating, but it looks more like a. Okay. Yes.
Sir, examination of the ipsilateral.
No, covered by.
Sacroiliac joints are normal on examination.
So how did you examine him?
Pelvic compression. Ganslin's test.
Ganslin also.
Ganslin you did.
You did Ganslin's?
No.
I did it when I thought there was no fixed flexion.
Hey, if there was no fixed flexion, you would do Ganslin. Here's a patient who's got a painful hip movements, painful. When you do a Ganslin's and you do an extension of the hip, the child might have pain. How will you know it's due to the pain in the hip or pain in the SI joint?
So patients' hip joint movements are not painful.
But
They're
even then,
restricted.
Tenderness was there, I thought. Tenderness is there in the hip joint?
you are inviting trouble.
There is
So-
mild tenderness around.
No, the pump handle test, Ganslin's test, don't say for examining the sacroiliac joint when there is a hip joint pathology. Period. So you will just say only the sacroiliac joint line tenderness or the pelvic compression distraction. These are the two. You must never say the other tests because it can be positive because of the pain in the hip. Okay.
Any other examination you've done?
Examination of ipsilateral knee and contralateral
Normal.
hip and spine are all normal. Sir.
Anything else?
Distal neurovascular examinations normal.
Anything else?
Yes,
See, you missed one important point. You mentioned about some lymph node. And you are very particular about infection.
Lymph.
Okay. I thought I expected you to at least say what area of lymph nodes?
Sir, deep inguinal and external iliacs.
External iliac, yes. Did you look for the external iliac nodes? Normal?
Nothing. There was no palpable swelling around the.
If you are not able to
Yes,
palpate
yes.
any, so you should bring it out. Certainly, because you were, first your etiological diagnosis was infection. I thought you'd tell about the lymph nodes.
How did you look for external iliac? Because I have never, I need to find.
Deep palpation above the anterior superior iliac spines.
Sorry? It is just above the inguinal ligament.
You have to flex the hip completely and then keep your hand insinuate above the inguinal ligament, roll your finger above. So that is what is described. And then try to palpate something. Sir, have you ever palpated and have you ever?
It can be palpable. It's in the pelvic side. Whatever you have to remember, it's in the pelvic area.
Flex completely above the inguinal ligament, roll your finger over the inguinal ligament, and you are supposed to see that. So definitely you must say about inguinal, external iliac nodes when you're right.
Okay, your diagnosis.
So my anatomical diagnosis is arthritis.
Arthritis.
So complete. So don't just say as
Arthritis of
arthritis, acute, chronic, right, left,
chronic
knee. So complete everything.
chronic arthritis of right hip, most probably due to infective etiologies.
Still, you want to stick on to that same infective etiology and
No.
arthritis?
But what features of arthritis are there?
Sir, a restricted range of movements, there's a fixed flexion.
From
deformity.
the
No, no,
beginning, you
it's
have
not
to-
just restricted range of movement, can be an ankylosis also, or an arthrophygrosis. Why is it, if you have to call it arthritis, it should be painfully restricted. I
At least an available range of movement is not painful.
So this is not the way you start answering. If you are answering, you say that it is arthritis. Why do you say it's arthritis? Joint line tenderness is present. Scarpa's triangle tenderness is present. Then, what are the features you expect in arthritis? Is there any fixed deformity?
Fixed flexion deformity.
Only
Flexion
FFD.
deformity. FFD is there. And is the range of movement painful?
No, sir, but it's terminally restricted due to spasm.
But terminally, when you do it, is it the 40 feet, the 30 degree of abduction, or is it painful, or even terminal, there is no pain?
Terminally painful.
Terminally, if you try to do it up beyond, why does the muscle go in for spasm?
Pain.
It is only because of it. Either it can be the range of movement can be decreased because of spasm, or it can be because of mechanical block. Do you think it is a mechanical block? It is a muscle spasm if you do it. So you suddenly.
No, but her
So this
gait,
is how you should.
gait
Yes,
is
yes, that's what
absolutely painless. You said you didn't say antalgia. If the patient had arthritis, you would have said antalgia. I am saying it's a synovitis of the hip. What is your problem? Terminal range of movements are restricted, not much of pain.
I'll give you one, I'll confuse you a little more. I'll give you some findings. There is true shortening, there is restriction of abduction and internal rotation with the fixed flexion deformity. You want to still stick on to arthritis, synovitis, or you want to take Coxa-Vara?
With those findings, it's more suggestive of cause.
That is your finding. That is the findings is there.
No, you have to say that if it is Coxa-Vara, what are the points towards Coxa-Vara? What are the points which are against Coxa-Vara?
So there's
If it is painless,
See, an infective etiology, probably tuberculosis, will have severe wasting. There will be deformities which are much more than what actually is there in the patient. It will be very painful, and he has not had any treatment. You said he did not have any treatment also, and somebody has given him a conservative management. Okay, so all the more your infection is ruled out here. Okay, so
how
if
much is wasting? Wasting was there because clinically you said
not much.
yeah, 1 centimeter.
1 centimeter. So that is very difficult to.
And with a tuberculosis infection, you cannot expect the patient to walk around without pain. Unless he's treated.
And he's been having it for quite long time. So synovitis probably the duration.
No, no, I'm telling you only on the basis of a range of movements. But if without pain, at least two planes of a movement should be painfully restricted. Then only I think you can put arthritis as a picture. And you should be very careful to put arthritis in a young boy. What arthritis are you expecting in this child?
What is the probable cause?
You have said arthritis. What arthritis?
Secondary to any developmental.
Secondary to arthritis to develop, it takes a lot of time.
Long time.
right? It's not something which occurs overnight or when a couple of months.
So what is the primary cause? So what do you think is the primary etiology? So you said secondary to some development etiology. So what is the etiology?
So. Yeah, tell me.
Could be Perthes.
Because this is not very definitive, because there are points for and against for so many things. So do you want to call this as a Coxa-Vara? What are the points for Coxa-Vara? What are the points against Coxa-Vara?
So there's an upriding trochanter, which is more prominent, and the shortening on the affected.
Is it
side.
point for
For
Coxa-Vara? Right, accepted.
and there's restricted abduction and
Internal rotation.
internal rotation.
Yes,
Trendelenburg sinus.
very good. So these are the points in favor of Coxa-Vara. Points against Coxa-Vara.
Anterior and posterior joint line tendons. Joint
Not
tendons.
necessary. Coxa-Vara can be with other.
Now, if you have a slip capillary epiphysis in an older child, it might be tender also. Just
Okay.
because it's tender, it doesn't mean that it cannot be Coxa-Vara.
Right. Anything else against? So all points of Coxa-Vara need not be there for a Coxa-Vara. So these are the points which are for Coxa-Vara. Against.
Fixed flexion deformity.
Fixed flexion deformity will be there in Perthes.
Not necessary. So it doesn't mean that it is not Coxa-Vara. Okay. A pure Coxa-Vara may not be there, but if it is there, it doesn't mean that it is not Coxa-Vara. Anything else? So if it is Coxa-Vara, in addition to restriction of abduction and internal rotation, there should be exaggeration of adduction and external rotation. So any one at least should be increased. So but all
My finding was definitely there was increase in external rotation and adduction is because I was able to appreciate it.
But definitely it is not there. So
External rotation definitely is there. So but probably we have done repeated
pain. So we are not able to demonstrate exaggerated external rotation or adduction. But definitely it is far better than when compared to the opposite side. So that is points for and against.
Next.
So if it is synovitis, you don't expect a true shortening of this much. But arthritis, there are other findings which are not. So it is not coming into the arthritis. It is not coming into synovitis where there will not be any true limb discrepancy. It is not exactly, but of all the three. So you have to choose something. So which is more appropriate? So only thing which we have, which is not possible is ankylosis, fibrous or bony.
Unstable.
Unstable.
Both are not
These
possible.
are not possible. These all these three, you can have a possibility. So what do you want to choose in this patient?
But I agree with what Dr. Shingarwadi is saying. At the end of the day, you weigh the pros and cons of both, right? Of arthritis and Coxa-Vara, which you are giving some points, which you think fits more appropriately for this patient.
Coxa-Vara.
Then stick to that.
Then why you
You
do not take it
don't
as
have to
first
have
option?
all 9 out of 9. You need 7 out of 9 is also okay because it's clinics. Well, the other one is 5 out of 9. So that makes it, so you choose which is most likely. Because you have two pros and cons, both. Yeah.
Infection and pain are
I want to ask the
much.
panel at this stage. So we have Coxa-Vara as a trochanteric Coxa-Vara, cervical Coxa-Vara, and capital Coxa-Vara. There are 3 ways you can get Coxa-Vara. So the capital Coxa-Vara is always a confusion, whether it is an arthritis or Coxa-Vara. So at this point, I think we should give a clear thing to them.
That's true. Whenever you are speaking about Coxa-Vara, people tend to think in terms of a neck shaft angle which is reduced. That's not always true. If you have a capital Coxa-Vara, like in a slip capillary epiphysis, the neck shaft angle might be reasonably okay. It's the epiphysis which is involved. Clear? So it can be at that stage also. So it's not necessary for you to have all the findings positive. So I fully agree with what Pashupati is saying, that you can have capillary epiphysis which produces Coxa-Vara. You can have subtrochanteric problems which is producing a Coxa-Vara.
Sir, in this case, it's very clear, sir, because
So epiphyseal involvement, you can have a Coxa-Vara which is not like the traditional Coxa-Varas at all.
Chronic slip.
so no, sir, because the diagnosis does not end up with Coxa-Vara. She is going to give an etiology.
Correct.
She's going to give a cause.
Correct.
Coxa-Vara due to Perthes. Then all these findings are fitting in.
Correct.
Then there is no doubt.
No,
Only Coxa-Vara, then there is an issue.
and arthritis is not fitting. Coxa-Vara is fitting. To me, from what I heard all of you saying, Coxa-Vara is an apt more apt than an arthritis. And then I think it's easier for you to defend yourself after that also.
Okay.
Take care.
What's the probable etiology? Mike.
Due to some developmental disorders such as Perthes.
So you want to put Perthes as first.
Yes, sir.
You want to think of any other diagnosis other than Perthes here?
How old is he?
11.
11.
11.
Do you have anything else other than Perthes in your mind?
Rocc and Varans.
You want to stick on to Perthes?
Why not a slip? The other condition.
So,
Slip capital femoral epiphysis.
What are the findings which are against slip capital femoral epiphysis?
That's all.
so
Will there be an FFT in slip capital femoral epiphysis?
no, sir.
Will there be an exaggerated extension in slip capital femoral epiphysis?
Yes.
Those findings are not here.
Yes.
Will there be an axis deviation in slip capital femoral epiphysis? That also
No,
is not very significant here. Okay.
Yeah, what Dr. Hiru is saying is absolutely right as far as slip capillary epiphysis is concerned when it's uncomplicated. You can get a fixed flexion deformity of a hip with slip capillary epiphysis if there's a complication. A complication, say avian or condylolysis, you can get that. So if it's uncomplicated, flexion is restricted and that much degrees extension is exaggerated because it's the change of arc of movement. So you should think in terms, if at all there's a slip, then it's a complex. There's a complication which has occurred in this.
So if you are asked why you're not thinking in terms of slip, there must be an answer. So in slip, we are not expecting any complication like that here because the range of movement is very good. So I always expect a hyperextension because it is the head which is posterolaterally situated, the arc of motion is changed. So there will be hyperextension, flexion is restricted.
Yes.
Second, the habitus, body habitus of the child. Usually it will be different from what the child is puny looking, thin, slim. So this is more against and that is more in favor. So you are left with this. So could it be still an infective, post-infective sequelae?
Yes, sir.
You still want to stick on to post-infective?
It's a differential diagnosis.
Yeah.
You started with an infective sequelae only. You presented it as an infective sequelae only. Even after your clinical history taking, you said it is most likely to be an infective sequelae. And then you brought up points which are painless hip movements, not so much restricted and everything. And you, after the discussion of the panel, you moved to coxa vara. So what did he actually present? I mean, initially thought to present. You wanted to take it as an infective sequelae only? Did it change because the panel was talking about coxa vara?
I was confused between arthritis and coxa vara. So
No,
now
it's
it
okay.
leans more towards coxa vara. So
Yes.
I
If you had
Initial pathological
been
diagnosis,
left
that's
like
what it is.
that.
pathology.
So
Infect-
arthritis hip, probably post-infective. That
Yes.
was your diagnosis. Because in the examination, you are asked to write the case sheet only because for these reasons. You cannot miss on your FFT. You cannot change your diagnosis at that. But we always perfectly understand and agree. If you could change your TAC finally after the panelists say few discussions. If you say and then probably I thought, but now I want to revise. Now I want to put first this, but I still want to keep infection in the back of the mind. Definitely that is okay. That is how you should change.
Okay, sir, time. So we'll go for the next. So what do you want to do for the patient?
So confirm my diagnosis
Any
with
questions from the
X-ray.
delegate?
Any questions from the delegates?
Yeah.
Any confusions?
So because these are the confusions which can happen in the examination.
Describe.
So this is an X-ray of a skeletally immature pelvis and bilateral hip, showing pathology in the right side. There's a break in the Shenton's arch. There's a proximal migration of the trochanter compared to the left side. There's a destruction of the
Why do you say it is proximally migrated?
So the greater trochanter.
Based on greater trochanter, anything else? The medial joint space, the teardrop, the distance from the teardrop. So always remember, the position of the acetabulum is the teardrop.
Yes.
Where the teardrop, the head has moved up. Okay.
There's a destruction of the femur head and the acetabulum. There's a
Acetabulum, there is it is totally destroyed, that you can see.
So is there any part of the capital femoral epiphysis which is still there?
some infromedially little bit. Part of the infromedial.
About the neck?
The neck appears to be broader compared to the opposite side. The greater trochanter apophysis also seems.
Pardon me?
The greater trochanter seems to be broader than the opposite.
Greater trochanter appears to be? What do you want to say? Greater trochanter?
So the greater trochanter apophysis also seems to be broader than the opposite side.
Broader. Very difficult to say because of the orientation. Okay. Because here.
That seems to be fused completely.
Hmm?
It's a fusion of the greater trochanter apophysis.
That depends upon the degree of rotation of
So
the.
you can see, that is what I was just trying to point out. So you can see that lesser trochanter to a certain extent, this is not that much seen. So difficult to comment. We'll just leave it. Okay, next. So how is the physeal plate? How is it located? And how is the neck? And what is this, what you are seeing here? And what does it look like, the picture? So acetabulum, is it looking destroyed? Is there a change? So much of destruction happening in the capital femoral epiphysis. Is there a corresponding destruction or any problem happening in the acetabulum, or
There's erosion in the. There is erosion in the.
there is erosion? You want to say?
And
So
the
in
source.
comparison to the amount of damage that has happened in the femur head, that's what sir is asking, the femoral head. Is there that much of destruction in the acetabulum?
So this entire femoral head is not seen. Only the medial portion is seen. Medial 1/4 or 1/5. The rest of the lateral 4/5 is not seen.
Lateral 2/3. Once you have the lateral view, anything on the lateral view which will help you. So the anterolateral part of the physis is very small. Whereas the posterior part is maintained. And the joint space is also okay. And the acetabulum is also not too destroyed.
Right. Looking at this X-ray, what do you want to think in terms of?
So, Perthes sequence.
Perthes sequelae or still the Perthes? Is it already gone to the stage of sequelae? Or it is Perthes?
Subluxate.
See, Perthes is always revascularized. You should remember that. The shape of the head might change. It's a temporary phenomenon to call it Perthes. So it will always revascularize. Is the head there at all for you?
Is there anything there or not in this place? There is nothing.
It's a little bit the meat.
No. What I am trying to ask, what sir is also asking is there an empty space here, or is there head which you are not able to see? Is it an empty space, or is there anything which is there? Because there is such an amount of space here.
It's an empty space.
Empty space. How is it maintained? So child is walking without anything, you don't see a telescopy. So how is this space is maintained? It is something like a cartilage in a space.
And you can see that what Dr. Chingarwadi will, there,
What
that
is
border.
You just
Lateral, yeah.
Look
see
at that.
here.
What is happening there?
What is here?
There's some fleck of
Impingement.
Impingement is okay. But what is there? There is a fleck of bone.
calcific bottom.
What is that? So you have to bring back all the theory what you have studied. I know you have studied all this theory, but you are not able to correlate this and that. Huh?
Like, that is one of the signs of head risk signs, the flex.
So what is the difference between avian and Perthes disease? Normal avian, is it a pediatric avian or is it different?
So avascular in Perthes disease, the first stage is avian, and then subsequently when the head, when the blood supply, when it
Revascularizes.
revascularizes, there's.
So it is a biologically
Sulfur.
plastic head where it revascularizes and again the head is formed.
Yes.
Unlike in AVN, there will be a collapse if the avascular necrosis, it goes to the grade 4, then it collapses. So it doesn't revascularize. Correct?
Yes, sir.
So in this, is there a possibility that this empty space will get revascularized and some bone will form, or it will remain empty, or it will remain in this kind of flat concave surface?
Revascularize.
So there is a cartilaginous head getting destroyed. Bone is being removed. So you're not able to see. If you take an MRI, you will see all the
Yeah,
portions.
that's what-
If you do an arthrogram, you will see.
If I wanted one more investigation to see that, you would ask for an MRI, right, to see the cartilage.
So it is the cartilaginous head which is there. So that is, these are the head at risk. So head is subluxing, the lateral calcification which is seen, horizontally oriented, and
Gauges sign,
gauges sign.
metaphyseal widening, all those 5 old signs of edited signs are there, all are there.
Yeah, but one thing you remember that head at rest signs are not been validated at all.
Yeah.
There's only one head at rest sign which is validated, that is subluxation. Right?
It's lateral
So-
subluxation.
Yeah, in this case, of course, that is there.
So finally, what it looks like?
Blood tests and all that you want to do? If you're thinking of infection,
Could it be TB? TB hits.
Still, it could it be tuberculosis?
Yes,
Is that,
could be.
yeah.
see, because you primarily thought of infection, it's not a bad idea to do your blood investigations also.
Definitely, till the end, till MRI and any other investigation, it says that everything is like this. You have to keep that. Okay. CT is done.
CT.
MRI is there?
Not done yet.
Agree with MRI?
Fine, only fine. It's very clear.
Okay. Postpone it, straight. Please, I'm just saying that. Okay. Right, so I assume that it is Pathi's disease and MRI is there, so what do you want to do now?
So in the initial stage, treat the patient with traction. And then subsequently, since the head is laterally subluxated,
See, all the head
Proc-
at risk signs are there. The head is almost getting destroyed. Okay, it's almost going to get destroyed. So what you want to do, you want to?
You want to stage this, you know the staging of herpes?
yes,
What stage is it?
this is Waldenstrom stage, fragmentation stage.
See, Perthes disease is up to about 9 years or so. Usually 9, 10. This is about 11 or 12.
Late.
Would you call it as late onset Perthes? Because the late onset Perthes has a much poorer prognosis as compared to a regular Perthes. They don't behave the same way. The treatment also is going to be extremely empirical.
So this is late onset Pathi's and extensively involved with.
Yeah.
So it should be done in. Yes.
No, I'd still go and contain it.
Now, I do an MRI. I make sure that it's not, because I am still not convinced that this is Perthes actually speaking. That there is a possibility there's some cartilage element there, but I'm not too sure about this being
It's
stated.
MRI.
Then it is Pathi's.
If it is Perthes, then of course, because I told you late onset Perthes has a different prognosis as far as management is concerned.
What you
Yeah.
will not say is, I do a varus denutation osteotomy and do corrective osteotomy. So it is
See-
very, very complicated than that. Okay.
And because remodeling, there are hardly any scope for remodeling. The age of the child is 1. Secondly, the epiphysis is already damaged. Epiphyseal plate is damaged. Hardly any remodeling is going to occur in this patient. And containment is not really an option in this child at this stage.
So what should be done?
If you want to, if the child has pain and instability is the cause, you will have to do probably some shelf procedure or something to maintain that.
This patient now doesn't have.
Yeah. That is the option that you can have now. If it is Perthes, if it's Perthes.
Non-lead guys.
Say,
What we used to do in ICH is shoe rise only, sir, or self, if at all. We don't do video in this case because
so don't say something like that.
and further we are getting full movement in percent. So after getting movement only, we have to go plan for a video. All our things.
I think at the MS level, it's controversial. So if you just say you give him crutches, the MRI shows there's cartilage and it's still in fragmentation or it's still not formed. You'll say you'll keep him off activity, give him crutches, give him traction for pain relief, and then again assess him after 6 months. It'll be a good outcome.
A VTO is contraindicated in a patient who got a hinged abduction. This has got a hinged abduction. The head of the femur is partly outside, right? If you abduct it further, you will dislocate the hip rather than get the head of the femur inside. So one thing is contraindicated in this patient is a VTO. Definitely it's contraindicated. If the head is subluxated and continues to be subluxed, then you will not do a VTO. You will do a valgus osteotomy. You will do a valgus osteotomy, right? So if the head of the femur cannot be brought inside to the acetabulum, then you will only do a valgus osteotomy.
The salvage procedures in Perth are valgus and shelf.
So in this is a classical case for a hinged abduction, which everyone should understand. So you have to take an abduction view. If you are not, or normally also before you plan for a varus derotation osteotomy, the aim is to take the femoral head inside the acetabulum so that the acetabulum will be the template for the femoral head when it is revascularizing and form a uniform round head. That is our expectation. But being in 11-year-old, we don't expect any remodeling. And here in this case, if the child, imagine the child is abducting, because when you do a varus, then the child has to abduct to keep it neutral. So when the child is abducting, this will hinge against this lateral edge of the acetabulum and the subluxation will go further. So this is the reason why, so you all understand from this, the most important take-home message is abduction, child will sublux. So varus derotation osteotomy is contraindicated.
He looks actually less than 10. It doesn't look.
A small child is also a sign of Perthes.
Yeah.
A child who's a little this way.
So only thing which he got carried away was the infection, and every time a low-grade fever.
And if you want to do it, you can do an arthrogram. If you feel that you are still not convinced it's an MRI, means it's a Perthes or not, and it's not infected, you're sure. You do an MRI and an arthrogram and see. If the hinge is there, abduction is there, then no, do not think in terms of video at all.
Yeah.
Then the plan for a valgus osteotomy. Or if the head is unstable, you can do a shelf and make it contained. That's a salvage procedure.
So infection, you want to keep in mind, is perfect till now, but that is not the only, you have to think in terms of. Okay, right. Very well done. Thank you.
We thank the members of the faculty for sharing your wisdom, sir. Yes. I request Professor Talkavi sir to honor the faculty. Yeah. Professor Singar, what do you say? Yes. Thank you, sir. Professor Thomas, sir. Thank you, sir. Professor Srinivasan, sir. Professor Tirunarayan, sir. Thank you, sir. We'll be now moving to the arthroplasty quiz for the postgraduates. I request Dr. Tarun to take over the stage. Following this, we'll be going for a short tea break.
வீடியோ கவர் பண்ணுங்க கீழே மேல 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 போயிடுவா You're going to be, yeah, I'll give order in the station. Here, they'll be walking. Okay, no. Okay, you use the color. No. நான் ஊருக்கு போறேன் பாண்டிச்சேரி நானே நாளைக்கு வர மாட்டேன் நானே ஹாஸ்பிட்டல் போறேன்
Check. Yeah, good morning, everyone. At the outset, I'd like to thank Professor Tolkapian sir and Professor Pasupati sir for taking this initiative. I'm sure all of you have your exams very close, at least the final years. Okay, so just like yesterday's session, but slightly different today, though, on arthroplasty quiz. I'm going to keep it simple. This slide might be confusing for you, okay, on how the questions are going to be, but just 5 questions for today. If we have time, we can go with more as well. Yesterday, I think, can just have a raise of hands of all the postgraduates so that I can just look at. All of you raise your hands, man. I'm not going to ask a question next. Okay, perfect. So all of you, okay, sir. So all of you, one thing that I tell you is, whoever wants to answer, stand up. Okay, no group raising of hands because I know all of you are very, very close with each other. And each of you know the other fellow might tell it right. Or the person next to you will be like, this fellow shouldn't win today. So let us get it wrong. Okay, so I don't believe in group answers. Billa Dairyama Yendriche answer sollalam. If you get it right, 10 marks. If you don't get it right, the person next to you or the next Dairyamana alku or advantage. 5 marks kadekom verum 3 options down. Unfortunately, rendu perkum if it doesn't work, both of you can still learn. See, the concept is 5 concepts for today. Okay, all of us are going to be winners in the future. That's the only concept which I have. So that's how it's going to go. Any doubts in this? All of you understand? If you get 5 answers right, and if you're confident and stand up for all 5, 50 marks and you win. Okay, if there's an alteration in that. All of you understood? Raise of hands of people who understood. No, if you don't understand, I'll explain, man. You understand, la? Okay, which college are you from? Interested in you? No, next him. CMC. Okay, I'm expecting something from you. You should stand up, okay? Okay, at least for that 5 mark answer. Okay, let's go ahead. Shall we start? Okay, yeah, perfect. Next. Yeah, so first question, next. Okay. All of these are established ways in which you do a femoral cut. Okay, so what is the proper femoral alignment in this except these 4? Okay. All of the following are established techniques to determine proper femoral alignment before taking a cut. Which among these is not a technique? Hey, stand up, man. Louder. Oh, tibia alignment. Who and all think it's tibia alignment? Wait. Who and all think it's tibia alignment? You can get up all of the others. You guys think it's tibia alignment? No, okay, sit down. But I'll remember your face. Okay, all of you are wrong. So 3 questions remaining. You get the next chance. Femoral alignment axis. How many of you think that's right? Okay, good. So that's the answer. It's femoral alignment axis. Next. One of you can help here. Yeah, so this is what is the concept for today. Good, I'm happy. What's your name? College?
Jeevanand, sir, Madras Medical College.
Awesome, Jeevanand. So you got the answer right. He has 10 points. Others from Stanley and CNC and Ramchandra and other colleges, get ready. So the 4 options are here. You can see I've color coded it. Red color is the tibial alignment axis. I'm sorry because it's changed. The blue color is your posterior condylar offset and the green color is your epicondylar axis. Okay. Femoral alignment axis, there is nothing called like that over here. So this is your transepicondylar axis. What do we want to do in a total knee? We want to create a rectangular box. Okay, this is the rectangular box. For the tibia side, it's same because mechanical and anatomical axis are same. Whereas for the femur, you insert something like this blue line inside, which is your intramedullary jig. And you take a valgus cut based on your valgus cut angle in order to get this rectangular box. Sometimes, like in hypoplasias and stuff, in valgus deformities, you need to trust this. So if the question, I tweaked it and I said, which is the main axis, how you take a femoral alignment? It is your transepicondylar axis. That is why you see this cut. So just like how your chiefs insert a spacer block in extension, this is the spacer block in flexion. You can after that attach a jig and take a cut. Okay, all good, awesome. Next. So patella clump syndrome, okay, usually seen in PS knees. So that is a learning point in itself. If you're planning to do a PS knee in the future, if your patient complains of pain, you need to think of it. Which among these is that? I'm sorry, ABCD is far.
Impingement of hypertrophic scar at the inferior pole of patella during extension.
Okay, anyone else? Like who is supporting him? Okay, the next person. Sorry, that's not the wrong. That's the wrong answer. I think he's already stood up. Sorry. The name?
Nishant
from
Chengalpattu.
Chengalpet. Okay, you get 5 points. So it is the impingement of the hypertrophic scar at the superior pole of patella. So this is what happens. You have a femoral box cut. There is more load in the front, causing a hypertrophic scar exactly at this pole. Okay, causing the pain to occur, and most often you require an arthroscopic debridement of it. So yeah, 10 marks to, I forgot your name. Jeevanand and for Nishad. So you have to, only 3 more questions remaining. Next. A patient is undergoing TKA in a valgus knee, which is 10 to 20% common. Okay. In extension, there is some tightness. What structure will you release? Someone. Okay, good. You stood up. Iliotibial band. Your name? Ganesh from
Chengalpattu Medical College.
Chengalpet Medical College. Exactly. So next. Very good. 10 marks to you, Ganesh. So this is a picture which I want you to take home. Take a photo, whatever. The next 2 slides is why I've come here. Okay. You need to understand this in order to become to have some knowledge on how releases occur. Okay. So I'll just try to explain. If you cannot understand, we don't need to continue the quiz. I'll explain it to you again. So this is how the iliotibial band comes. Okay. Can you see the articular surface over here? Articular surface is perpendicular to the ITB band, which means someone is keeping a hand here, which means they are right on my face, which is perpendicular. Whenever something is perpendicular, it causes tightness. The same iliotibial band, you see what's happening over here in flexion. What is happening? It is louder, man. Parallel. If it's parallel, what will it do? It will walk along with you, which means it's not going to give you stability or resistance. So there's no point of you releasing it. Exactly. So when you are having tightness both in extension and flexion, you need to think of the LCL. When you are thinking of tightness in flexion, you should think of the popliteus, which is underneath the LCL but in front of it. If you are thinking if it's extension, you have to release your IT band. Next slide. Here you can see every joint, every side has a static stabilizer and a dynamic stabilizer. Dynamic in the word keeps moving, okay, which is muscle. Anything which is static is tight, like a capsule or a ligament. Within that same capsule and ligament, you have a front fiber and a back fiber, which is anterior and posterior. So look at this fibrillations over here. Yeah, you can look at this in flexion, the anterior fibers are tight, whereas in extension, the posterior fibers are tight. That is why when you need to release and get maximum flexion in a varus deformity, you need to release the last structure will be your release of pes anserinus, okay, which is going to be more behind. So try to understand everything is about what is tight and what is loose. You can see in flexion, this is parallel to the joint. So there's no use of you releasing your pes anserinus, and rather it is important releasing your superficial anterior fibers first. Okay. The whole concept of alignment is something which you're going to be listening for the next 10 to 15 years. But try to understand inside that operation theater, only you are there, and the anatomy and what your teachers have taught only will be there. Okay. So try to understand this, go home and read this again. So 2 more questions. I would urge the both of you all to be ready. Okay. So in patients with type 3 and type 4, which is done? Like A, B, C and D. Extended trochanteric osteotomy. No. Next. Yeah. Subtrochanteric osteotomy. Correct. Next. Next slide. So what is the problem? You need to understand getting back the center of the joint is the most critical when you do any replacement. Offset and management of it is the most important. That's why your teachers teach for intertrochanteric fracture, don't use the word replacement, because to create that offset is more difficult. Okay, in these cases like type 3 and type 4, you want to bring it, you need to get back the length and alignment. So this is the technique in which wherein you try to initially go create that wedge, keep this on top of the other, and then see how much amount of bone is taken in order to accept what center is. So the learning point from this is you need to know that there is a Crow classification for dysplasia in which there is 1 to 4, and in type 3 and 4, a subtrochanteric osteotomy. You cannot use a proximal fitting stem. You have to get a diaphyseal fitting stem in order to perform this, in order to get back length. Patient will have shortening, but that is acceptable as long as we provide stability. So he's leading the last question. So yeah, both of you get ready. Next. A 68-year-old woman, as all of us do, uncemented hip is being done exactly when they are finally trying to insert the final, and when you're holding the leg, you're saying to bang it, and someone puts a suction there and they notice a undisplaced crack. What will you do? Unfortunately, I'm only sticking to these 3 people. I'm sorry for the rest because of want of time. First, will you remove it and cement that and put the same stem? Okay.
Option 3, sir. Removal of implant, placement of circulage wire around the femoral neck, and lesser cutter and incision.
How many of you think he's right? You can raise your hands, man. So he's the winner. Congratulations. So he gets 20 points, and that's the answer. Next. So this is a learning point for you all. Next. All of us do a lot of things. Yeah, all of us do a lot of things. Most common, okay? We are forgetting the art of cementing, but you can see a lot of papers being published on how DOR type C or age beyond 70 or 75 cementing needs to be done. Because of the warrant and because of improper learning, we are unable to do it. So when you do these, when you want to fill the canal fully, you'll get this cleavage or a crack. Nothing you need to do, get it back, see whether it is crossing the LT, whether it's extending 3 centimeters or more, lock it up, implant the same, try to see weight bearing based on how the patient was mobile prior to surgery, and that would work. Okay, awesome. So all of you learned 5 techniques or 5 concepts today. I'm more than happy with that. Next. Next. Yeah, so all the best for you all. I'm sure all of you are going to rock it in the future. Continue learning and please continue teaching. Okay.
Thank
All
you,
the best.
Dr. Tarun Prasad, for a very
Thank you.
educative quiz.
Sure.
I request Professor Singareddy, sir, former director, to give the prize money to the winner, Jivan. Congratulations, sir. Okay. Thanks. I also request Professor Singareddy to hand over the memento to Dr. Tarun. Sir.
Prize money is sponsored by Dr. Sanu Sundaram Srimosa for XMC. So 10 minutes tea break.
Mic check. Good afternoon, and we welcome to this next section of peripheral nerve injuries, including brachial plexus. I thank the team of MMC, Rocc, Tulkapin sir, and the entire team who called me here for this opportunity. We'll have a quick session of 3 vital cases here, and we'll have a short discussion, and then we'll have a brief, how to examine those injuries, and then how to manage, and subsequently what are the treatment options. So it'll be a short case except the brachial plexus. All nerve injuries are very complex, but if you can take that case, I'm very sure that definitely you will easily walk through, because all these nerve injuries are simple mathematical calculations. It'll be very easy for us to understand and also to convince the examiner that you have completely thoroughly examined this patient. They ultimately want to see how I'm going to examine this patient and how do you arrive to diagnosis. And most of the examiners do not want to understand what surgery you do, what are the approach they want to. These are what to understand how do you approach the diagnosis and how you arrive to that diagnosis. So with this short introduction, I have my the co-teacher here, Dr. Chokalingam sir here. We will have these 3 cases quickly examined. Quickly, we'll present all these 3 cases. If you have any doubts, please feel free to stop in between, because this is one thing which you need to understand. Feel free to ask any questions in between, so that we'll be happy to explain you why this and how this. Thank you.
The 28. Shall I say?
Which case you're going to present? Number. Okay. He's going to present this page.
I am Dr. Haribasan, sir, final postgraduate from MMC. 28-year-old right-hand dominant male, Mr. Kamaraj, who is a saloon worker by occupation from Dharmaburi, came with the complaints of weakness of the right upper limb for the past 4 months, and numbness over the right upper limb for the past 4 months. Sir. The patient was apparently normal 4 months back. Then he sustained a road traffic accident and had injury to the right shoulder and the right leg. So, following that injury, the patient was unable to use the right upper limb and numbness over the outer aspect of the shoulder, arm, and forearm and hands. Not associated with radiating pain and associated with difficulty in combing hairs, bathing, and difficulty in wearing cloth, and no history of neck pain, no history of seizure, and past history. Patient. The patient was operated for a left hand injury 15 years back and had a history of surgery for the right leg 3 months back. He had wounds, sinus discharge actively in the right leg, and no history of recent vaccination. History of recently diagnosed diabetic mellitus and hypertensive. And personal history, the patient consumes alcohol for the past 7 years, 5 days a week, 180 ml of brandy, and history of smoking for the 7 years, 3 cigarettes per day. No significant family history. General examination. Patient moderately built, nourished.
May I interrupt you? like from the history.
Yes, sir.
So what are you trying to convince the examiner? What area of focus you are going to? I mean, what is the diagnosis like you're trying to convince us? Like where are you focusing? There's weakness
Yes, sir.
and difficulty in using the right upper limb with sensory loss.
Yes, sir.
So what does it strike to any examiner? It's a 4 months duration.
Sir, immediately following, he had a weakness.
He sustained an injury.
Yes, sir.
Following injury, he had developed immediate weakness or
Yes.
what you call weakness in right upper limb.
Upper limb.
Cannot use the upper limb. That's after the injury.
Yes, sir.
In the history, have you ever noticed that patient said, sir, after the injury, I didn't have any movement at all. But subsequently, over a period of time, I noted my fingers are moving. I could use my hand to bend something.
Yes, sir.
Would you ask this question or would you say directly that he has complete weakness in right upper?
Sir, he was able to use fingers.
You understand my question?
Yes, sir.
What, see, the question why I'm asking is because was it a complete injury or a partial injury? So to the history, from the history,
Yes, sir.
you need to say that, sir, from the history, he had an injury following a bike accident.
Yes, sir.
He was admitted to hospital, whether he had head injury or not, whether he had associated fracture or not. These are all very important findings because they are high energy injuries where they invariably have some other fractures. If not, as well and go. So you say that, sir, he had injury around 4 months back. So after that, he noticed some improvement in the hand, or from the day of injury.
No improvement, sir.
From the day of injury, he had complete weakness in the shoulder. He cannot bend the shoulder or lift the shoulder in a simple term because you are in the history. He cannot lift the shoulder, he cannot bend the shoulder, but he can move the fingers. This is very important because you're trying to take us to a particular location where we need to focus. With the history, if you say that complete weakness and absent sensation, you're not going to take us to anywhere.
Yes, sir.
Understood? Yes. So from the history, you are trying to say that this is a partial type of injury. It could be anything else.
Yes, sir.
It could be a partial type of injury. And we need to focus on that particular portion of examination, right? You're taking us to that. Can you revise the history shortly and tell me how exactly happened?
Yes, sir. The patient history of
Short history.
4 months back after sustained injury to the right shoulder, and following that he was unable to raise the shoulders, bend the elbow, but able to fold the fingers, and no history of progressive increase in weakness or improvement.
Yeah. So take two things. One, from the day of injury till date, sir, he had no movement in the shoulder and elbow, some movement in the fingers and the wrist. And there is no improvement in those area where he had weakness. We can say that this injury happened somewhere involving the shoulder, elbow, and has some restricted or some movement in the wrist. So you're taking us to some particular portion of one lesion where we'll definitely want to examine how do you do that, right? Anything else in the history? Okay, go ahead.
I think the treatment history.
Sir,
What treatment? 4 months ago, he had
Yes,
a
sir.
surgery to the right leg.
for
Right upper limb, did he have?
shoulder injury, here there was no intervention done, sir, for right shoulder injury.
So there's no medical or surgical intervention.
Any intervention done, sir. For a leg injury, he had a surgery, sir.
Okay.
You need to focus, you need to take us to a particular diagnosis, sir. This is what happened. So we will focus only on that particular area so that we are prepared, that you have been thorough in the history, right? Go ahead, go.
Yes,
General examination to relevant points.
yes, sir. No meiosis.
Start with the general examination.
Yes, sir. Patient moderately built, moderately nourished, and no pelvic tears, no cyanosis, no clubbing, pedal edema, generalized lymphadenopathy. No meiosis, no.
Tell me the
Enough
positive
thermal-
finding. Tell me the positive. You can come to the local examination directly.
Examination.
You can directly see, plan in such a way that you start with the local examination,
Yes, sir.
inspection, palpation, and motor examination, sensory examination, vascular examination, finally special test.
Yes.
This is how you do it for any long case, right? You can follow the same order.
Patient in a sitting position, sir. Exam attitude, shoulder widely flexed, and elbow flexed, with the forearm and hand supported by the left hand. And there are fingers are flexed mildly. And there is a prominent spinous process, scapula. And there is hollowness of supraspinatus fossa, infraspinatus fossa, and visible wasting of a posterior axillary fold. And there is a groove between the in the subacromial region, and there is a wasting of deltoid region.
This is what exactly we want. See, we want the positive finding to say that the shoulder is wasted, the elbow or the arm is wasted. There is weakness or wasting in the hand. We need to say that there's an intraosseous wasting. So inspection, you have to take us that this is where the shoulder is involved. The elbow is also involved. Or in the post of the hand is also involved. So the positive finding, if I am there in your question, so the marked wasting around the shoulder, both anterior and posterior, and wasting of muscles around the arm or proximal arm. And is there any wasting in the intraosseous muscles?
No, sir.
In the palm?
No, sir.
Have you seen?
Yes.
Is there any wasting here?
No, sir.
The hypothena okay here?
Yes, sir. Similar.
Okay or not okay? Okay. So,
Yeah, stick to your point. I don't see any wasting. You can say, I can't appreciate it.
is there any wasting in the thenar?
No, sir.
Because he has some weakness in the hand, you're trying to say that there is no wasting in both thenar and hypothenar. So on inspection, there's marked wasting
And
around the shoulder, proximal arm, and any relevant finding to say that, apart from that, is there any other relevant finding, the attitude, because he is being seated here. Otherwise, what happens in brachial plexus, if the shoulder is weak or shoulder doesn't have any function, then the shoulder goes down because there is no deltoid acting there, and the elbow is also very flail. So there will be some sort of dragging here because of no shoulder function. Because to prevent this, what happened, the patient tried to compensate by lift. Okay. Check. So this patient cannot stand. Otherwise, we ask patient to stand, there will be a sagging of the entire upper limb. There will be a sulcus seen because of wasting and absence of deltoid function. And because there is no muscle function here, it tries to compensate by lifting the head or shifting the head towards one side, the other side. The other patient can definitely exhibit the finding, he can stand. Because of the weakness around the shoulder, so there will be definitely obvious halo or wasting around the proximal shoulder, can insinuate the hollowness. You ask him to leave, he'll definitely see that. So there is definitely a wasting here. Being a thick build, probably you will not find that. So you can say that the sulcus there. These are all trying to say that the shoulder muscles are not working completely, they are weakness or completely they are paralyzed. This is an inspective finding. Any other finding which you can say that you are taking us to brachial plexus. Now we are in the examination, right?
Yes, sir.
Come in the front. Now tell me. Apart from the wasting, apart from weakness, apart from the drooping of shoulder and some intraosseous wasting, anything you want to say in inspection that you are trying to take us to that particular level of lesion? You can start seeing his eyes also. Look at him and start looking at it.
Oh, you can articulate what you're looking for.
Exactly. So from the inspection, you wanted to convey that, sir, I've checked this patient for a CAT1 lesion and say that, sir, there is no meiosis or there is no features of hardness in this. So this makes us more impressive that you have been to the point or to exactly focus to some particular lesion of the brachial plexus. So you can say that, sir, there is no features of hardness syndrome. And obviously, there is no surgical scar of any other surgery which has happened around in the entire upper limb. Why? Because there might also be other procedures happening around the shoulder or other injuries which might have also caused lesion to nerves, peripheral nerves. For example, they might have had some surgery over the humerus. You may not corroborate this finding to a wrist drop. So you are trying to say that you have ruled out other possibilities and you are only narrowed down to your brachial plexus. So apart from these things, you have to say that, so there is no features of hardness syndrome like meiosis, ptosis, or anastomus, and there are no features of trophic ulcers. Why? Because mostly what happens, they are completely asensately. So they try to, find out whether the harm is working or not, or somehow inadvertently they cause injuries by hot water or some sharp objects. So these people will have some trophic ulcers. These are the findings to say that his limb and the hand is quite sensitive. Understood? It's quite sensitive. You're taking us to some particular portion of lesion. Okay, anything else on the inspection? No features of hardness syndrome and any other findings that is not relevant to your diagnosis, right? There's no trophic ulcers and is perfectly okay with the inspection. So from the inspection, you would have come out to particular portion of interest. So which portion of interest you are going to specifically examine now? Some portion of brachial plexus, right? Palpation.
Palpation.
So is the sulcus which you do, say the same as the sulcus in inferior arteries.
So the idea of sulcus is that there is a complete wasting or complete paralysis of delta. So this is what we mentioned here. That's quite different from multidirectional instability, where the delta is functional there. Because of the ligamentous instability and the sulcus or whatever dragging is happening. But here it is because of complete muscle loss. Around the shoulder, commonly deltoid. By this, you're trying to say that deltoid is not working. Simple. Right? Oh, palpation.
Palpation. No alteration in temperature and the bilateral.
Relevant points. Relevant.
Yes, sir. Tenderness present at the lateral end of clavicle, subacromial region, and medial and lateral aspect of the elbow, and distal radial ulnar joints. And
does it have any significance to the diagnosis? Does it have any fracture here? To the positive finding. Anything positive, you say that from the palpation.
Yes.
Anything positive? No positive. Okay. Then special examination.
Movements.
Whatever, whichever way you have been doing that, you can go ahead with the long case here.
Yes, sir. No active movements present at the shoulder joints, and no active movements at the elbow joints, and absence of wrist extension actively.
Dorsiflexion, wrist dorsiflexion. Wrist dorsiflexion is 0/5, right?
Yes. And finger thumb extensions are absence active movements. And passive movements, no contraction, stiffness seen in the shoulder joint, elbow joint, wrist, and finger joints.
That's special test.
Yes. Neurological tone of the upper limb is a flaccid hypotonic, and there is a visible muscle wasting over the periscapular arm and forearm muscles. And power examination. Power. The patient able to strike both shoulders. And rhomboidus major minor as contracting.
Sure.
Yes.
Sure. Yes. Okay. So before moving to the motor examination, I'll try to elicit how to do this, all those examinations, and then probably you can definitely then show how to do the test. So before going to this, examination, I think there are few things, vital things the examiner would like to want to understand from the postgraduate. One, whether it is a complete injury or a partial injury. So from the history, you're trying to say that there is some movement which is preserved in this patient, right? So it is not a complete injury. Complete injury means C5 to T1. The other question which examiner would also, from the history, would understand is that whether there's any improvement in the movement or improvement in the function. Say, for example, injury might have caused neurofracture type of injury, and by 3 weeks or 6 weeks time, it slowly start getting movement in the hand. These are all two different types of presentation from the history, right? Okay. Now, for the motor examination, I'll say few mathematical solutions where it will help you to understand any brachial plexus injuries. I've been re-emphasizing this again and again. So C5 is for shoulder function, right? So you just try to re-emphasize again. C5 is for shoulder function. Shoulder function is something like you lift the shoulder. C6 is something like a elbow flexion. C7 is elbow extension. And C8 even for the hand function. If you can remember this mnemonic or this simple mantra, you can come to the diagnosis without touching this patient. Now tell me what is the diagnosis without touching the patient? Roughly. Roughly, I'm focused on it's a patient who has brachial plexus injury of C5, C6, C7. Roughly in your mind, right? Because no shoulder, no elbow flexion, no elbow extension, some movement in the hand. So roughly your mind should be there that I'm dealing with a C5, C6, C7 injury. Whether it is C81 or something else, you will come to the diagnosis of motor examination, right? So far, any other doubts in diagnosing a patient of this kind presentation? So anybody who can come to OPD by asking the patient to lift the shoulder, bend the elbow, extend the elbow, you'll come to a diagnosis. Because most common injuries are C5, C6. The next common is the C5, C6, 7. And the most common is complete brachial plexus palsy, where the entire limb is completely weak or you call as paralytic. This is the presentation of brachial plexus, right? Now, other mnemonics, say for example, if the criteria doesn't fit, for example, the patient does not lift the shoulder, but can bend the elbow. Understood? Patient cannot lift the shoulder, but can bend the elbow. Does this matches you? Doesn't have a understanding of could be a C5 alone or could be something else. So if you have some other problem, say for example, if you don't have a simple solution of shoulder lifting, elbow bending, elbow extension, if you have some other finding that is not matching you, then think of coming to little down. That is either a supraclavicular or an infraclavicular. So brachial plexus are two portions that is somewhere around the clavicle, above the clavicle, below clavicle. Above the clavicle is straight forward. C5 shoulder, C6 elbow flexion, C7 elbow extension, and rest the hand function. If you find something not matching this mathematic solution, you come little down. There are infraclavicular injuries. They have different presentation. That's very simple. Either this C5, C6 mantra or something down. There are three cards, right? You have the three cards and mnemonical three cards. The posterior card is the mnemonic is ulnar, right? Ulnar alta. The upper subscapularis, lower subscapularis, nerve to latissimus dorsi, axillary nerve, and radial nerve. If you don't find the simple solution of C5, C6, C7, then come down to the diagnosis. It could be either one among the cards. It could be a posterior cord, a lateral cord, or medial cord. So what are the mnemonic for the lateral cord? We call as LML. So L is for the lateral root of the median nerve, M for the muscular quadratus, and other L for the lateral pectoral. And for the ulnar nerve, MUM. This is what I have been remembering. So medial root of the median nerve, U for the ulnar nerve, and M for the medial pectoral. So these are all the motor component. So if we can fit any of those things into the card, then the level is at the card level. If you don't match C5, C6, C7 mantra, you'll come little down. And if you could put this into any one of the card, then you can say this is this particular injury. Okay, this is how we approach. Now, you know that this is a simple injury where C5 is not working, C6 is not working, C7 is not working. Now you have the diagnosis of C5, C6, C7 in your mind. Do not say that. Are we sure that this is C5, C6, C7 injury? But there is something you need to add to the diagnosis. So for that, you need to do motor examination and to say what is working, what is not working. So now, any doubts from this so far in diagnosing? Diagnosis is very simple. You need to convince the patient that the examiner that this is what the diagnosis, and based on the diagnosis, this is what my presumptive diagnosis or a diagnosis which I can provisionally say. All right. So now you can go ahead and tell me the other possibility finding to say that what you have checked in this patient.
Wrist extension and a finger extension and thumb extension are absent.
So he has a wrist drop. So he has a wrist drop, and tell me what is working and what is not working.
Finger flexion and finger abduction, adduction. So working, sir.
Demonstrate. What are you trying to demonstrate? Sure. Finger flexion. What are finger flexors? FTS and FTP. So flexor distal supination, it flexes the proximal interphalangeal joint. The FTP flexes the. So you're trying to find both in one simple way, or is there any other way you can find the FTS?
Based on that. Doctor, what are the
Speak, you speak.
The barrel madaga able to flex.
I'm telling this is because of FTP.
Sir, FTP we have to stabilize.
Tell me that. I'm telling this is because of FTP. FTP can also bend the PIP joint and the distal interphalangeal joint. I'm telling you this is because of FTP. You prove me wrong.
It cannot act in singular.
It cannot. See, one simple way is that. See, pa, தம்பி, இங்க தெரியுதாப்பா? இங்க தெரியுதா? One simple way is you can restrict the other finger flexion and ask him to flex. Watch the movement. Now, if FTP is acting, if FTP is acting, this DAP joint will be free. This is free, right?
Yes,
It means that it is flexion at the PAP joint. What happens otherwise, if the FTP is acting, he will always try to keep in flex position. He will not allow it relaxed. So you need to show that this is the function of the proximal axial joint flexion, that because of the FTS. As a ring finger,
There is a flexion at the proximal.
feel for the DAP joint, that's completely relaxed, right?
Yes, sir.
Okay. So finger flexors are working. The FTS is working. FTP.
Distal interphalangeal and flexes.
You need to check whether it is working simply by restricting the movement of the IP joint, the PAP joint flexion. Always check for the power. So it's good. That means working. Other finger. Good. Other finger. Sure. Working.
Yes.
So the flexor distal promoter is working. Now tell me, the index finger and the middle finger FTP is separated by?
Index and middle are supplied by medial.
Okay. Little and the ring finger? So tell me, you keep in your mind. Now I have checked this patient where both median and the ulnar nerve is working.
Yes.
On the contrary, the radial nerve is not working. So this all helps you to a diagnosis, right? So you can come to a diagnosis that this is working towards median and ulnar nerve.
Yes.
Now go ahead.
Check the radial.
That's not working.
Yes.
Wrist is dropped, fingers are not working. Any other test to say that both median nerve and ulnar nerve are intact? Pattern. Otherwise, you check the functions or test for ulnar nerve palsy.
Yes.
Like into the mic.
Patient can hold the cards,
Sure.
but not film.
Putting it. Putting it. அடுத்த ஆள் நீங்க. அடுத்த ஆள். ஓகேவா? சரி. இப்போ வாட் இஸ் திஸ் மூமெண்ட்? மடக்குங்க. விரல மடக்குங்க. ஃபிங்கர். விரல ஃபுல்லா மடக்குங்க. நீட்டு. வாட் இஸ் திஸ் மூமெண்ட்? மடக்குங்க.
Lumbricals,
Only lumbricals.
introsh.
So this is the function of the introsseous, which helps in flexing the MCP joint at the same time extending the IP joint. Why he cannot do with the wrist drop?
Sir, finger extensor, finger extensor weak.
So what?
Lumbricals can act, sir. It causes a flexion at metacarpophalangeal and extension at interphalangeal joints.
That's only in the hand.
Yes.
Why do you want to stabilize the wrist?
There are
Something to. What happens? The wrist synergy is something like when you flex the wrist, fingers go into extension. What does happen? On the contrary, when you extend the wrist, fingers go into flexion. What does happen? This synergy. Synergy are nothing but the excursion of this wrist flexion and the finger extension are more or less the same. When you flex, extends. These two synergy excursion are same. Contrarily, when you do this, what happens? This synergy and the finger flexes are same. You're trying to neutralize this, trying to get this synergy working by stabilizing the
wrist
and then you're checking the
functions of introsh.
because you're not sure whether the finger flexors are working or the introsseous are working. Okay, that go ahead. Tell me what I'm going to do so that everybody can see. Which one? This is called as Froman sign. What are you going to check in this Froman sign?
And the
Right up.
right of which
What are you going to check in this sign?
flexor pollicis longus.
நல்லா பண்ணிட்டு இருக்கீங்க.
Flexor pollicis longus is working in this
Working,
case.
sir.
So what are you going to try in this test?
Adductor-
What is the one which is preventing between these two, thumb and the index?
Adductor pollicis.
Adductor muscle. The adductor pollicis in between these two tries to retain the card by contracting. If it doesn't contract, he or she uses the flexor pollicis longus, that IP joint of the thumb will bend to hold the card, right? Do it. Okay, right. So and few functions or few tests for the median nerve. We have done the FTS and few tests for the median nerve.
Abductor pollicis
Yeah, try showing that. And speak what you say. What do you do?
Better which to the is
And
able
always
to
feel for the contraction. Always feel for the contraction over the thinner muscles.
thinner.
So these are all entire thinner muscles. Even though it contains abductor pollicis brevis and the opponent's pollicis and the flexor pollicis brevis, this is called as thinner eminence. We roughly examine by asking to abduct the thumb and feel for the contraction. Right?
Yes.
Is he able to do?
Yes, sir, able to.
Okay.
Yes.
Okay. Then few tests for median nerve to say that is intact. Something like O. It's stabilized. Speak what you're doing and what you're checking also.
சத்தமா பேசுங்க.
Yes. Check flexion and
By
distal
making a round, by making a O, what happens to the thumb?
flexion at distal interphalangeal.
Okay, IP joint. The thumb has only two joints, right? The metacarpophalangeal and the interphalangeal joint. The rest of the finger has three joints, right? MCP, PIP, and DIP.
Yes.
Okay. So now the thumb flexes at the IP joint
Yes.
because of
Flexor pollicis longus.
longer. That's separate by the
Median.
okay. And the index finger,
Index finger median longus.
FDP is flexed. It means that the median nerve is intact. What does happen if the thumb goes like this? There is no flexion at the IP joint of the thumb, and those with flexion at the
Intellectual-
DAP joint of the index finger. Meaning to say that the median nerve is not working. What portion of the median nerve is not working here? See, whatever you checked previously will say some portion of the median nerve. This test, what portion of the median nerve you are checking? So median nerve can be low or high, right?
Yes, sir.
So what you checked before is a sign to say that whether he has a low median nerve palsy.
Yes, sir.
And this is the test which shows that whether he has a,
High.
which is the one which differentiates between low and high.
Sir, if it supplies a flexor digitorum.
We call as the anti-introsseous nerve. Okay, the median nerve divides somewhere in the mid forearm into anti-introsseous nerve. Anything involving the anti-introsseous nerve which supplies the flexor pollicis longus and the
Flexor digitorum
profundus and also pronator quadratus, which you may not check in this patient. So you can say that you can come that okay, this is something like a low median nerve or this is something like a high median nerve. So from these two tests, simple tests, you are very sure that there is no involvement of median nerve, either low or high. You're sure?
Yes,
Right. Now check me, tell me whether the ulnar nerve is intact, whether the low ulnar nerve is intact or high ulnar nerve is intact. You understand?
Yes, sir.
These are all will take you to diagnosis where you are working at.
Yes.
You've done few tests for ulnar nerve and some tests which can show that this patient has a high ulnar nerve pulse. So tell everybody what it is.
Can able to feel the
I'm trying
contraction
to-
of flexor carpi
I'm
ulnaris.
trying to ask the patient to make a fist and or keep the fingers straight. Ask the patient to flex the wrist towards ulnar side, right? And feel for the
Contraction of
contraction of the FCU. This is one test. Now tell me, does he have claw hand?
No, sir.
So if I ask you whether this patient had a high, low ulnar nerve or middle nerve, you should have said that this patient does not have any features of claw hand, right?
Yes, sir.
So this is one way of addressing the examiner. I checked the ulnar nerve, either low or high. He doesn't have claw hand and the FC is working.
Yes.
So you're very sure that your diagnosis is somewhere around involving two nerves which are intact.
Yes.
Now, anything else you want to check?
Tinelsen.
Tinelsen. How do you do Tinelsen?
From distally to.
Start doing this patient. Tell him what you want to do. Tell him what you want to find in this patient. Tell him.
கீழ வந்து விரல தட்டுவேன் ஒரு இடத்துல ஏதாவது ஷாக் மாதிரி அடிச்சிச்சுன்னா சொல்லுங்க.
Okay. So which portion, like which nerve you are going to do? Try showing that.
அல்னா
Try doing that. தட்டுவாங்க எங்கேயாவது ஒரு இடத்துல சுருக்குன்னு ஷாக் அடிச்ச மாதிரி இருந்தா சொல்லுங்க. Do you expect something to happen here?
No.
But elicit. This is a part of finding. Go ahead. Shock அடிக்குதா? Up to the brachial plexus. Shock அடிக்குதா? So you are not elicited the brachial retinal sign, right? இங்க அடிச்சா ஷாக் அங்க மட்டும் போதா கீழே வருதா? These are all some finding which will take you to diagnosis. For example, you tap here at the supraclavicular area. If it goes to the somewhere around the shoulder or elbow, correlates to C5. Comes to somewhere distal to the forearm, C7, C6. To the palm onto the dorsum, C8. Right? So these are all few things which will help you to say that tinel sign, I found tinel sign that's coming around to the shoulder area when I tap over the supraclavicular region. So there might be involvement of C5. Are you sure, right?
Yes.
This is how you have to do that.
Yes.
Anything else? We'll do that. Anything examination. Pulse is okay.
Yes.
Pulse is okay. Now you have done complete examination. History, you told me that 4 weeks or 4 months, the hand is weak and there is no improvement, right? So you are focusing something towards a lesion somewhere involving the few portion of the brachial plexus.
Yes,
That
sir.
we do not know from the history.
Yes.
On examination, you found that the ulnar nerve and the median nerve is working.
Yes.
And apart from that, the other, nothing is working. Sure.
Yes.
I'll give you one chance. Check one more other finding, which will tell you the diagnosis. What examination? Anybody want to do that? Then we want to do some motor examination which will help you to diagnosis. I told you simple mantra, C5, C6, C7, that's okay. Now, we need to find this patient has C8 or T1 lesion, right? This is the finding. Which is the portion which are going to help here to say the diagnosis? Which one muscle test will help you to do the diagnosis? Okay, you tell me those posterior cord muscles. Okay, what are the posterior cord muscles? Are they working? The abduction is not working. Triceps is not working.
Triceps, no.
The upper scapular, lower subscapular have done this.
Yes, sir.
Not working. I'll tell you how to do that. Not working.
Not open.
And
The post-
axillary not working, radial not working, nerve to latissimus. Is it a posterior cord injury?
Sir, yes, sir.
Anybody? I say it's a posterior cord injury. Because the mnemonic is ULNAR, upper subscapularis, lower subscapularis, nerve to latissimus dorsi, axillary radial nerve. Have you checked the latissimus dorsi?
Yes.
ஐயா அந்த நேரா பாருங்க நல்லா இரும்பு இரும்புங்க ஒர்க்கிங் ஆர் ஒர்க்கிங் இரும்புங்க
Not working.
இரும்புங்க ஓகே then is it a posterior cord injury?
Sir, above levels, not cord injury.
Why cord injury?
Okay.
You have done the posterior cord, so you are trying to fit this to the posterior cord. Check the lateral cord. What are the lateral cord features? The biceps,
Elbow flexion, sir.
okay,
Yes.
lateral pectoral nerve and lateral root of medial nerve.
Yes.
So I'm trying to give a clue. So you have checked the medial nerve that is supplied by either the lateral root of the medial nerve, that's by the lateral cord, and also medial root by the
Medial cord.
medial cord. So medial nerve is working, you have checked it.
Yes.
Biceps is not working. Which is the one thing you have not checked? Lateral pectoral nerve. So the lateral pectoral nerve checking will take you to the diagnosis. Okay,
Yes.
check for the pectoral. Which portion of pectoral is working here?
Sir,
Lateral pectoral nerve.
Yes,
So it
sir.
supplies which portion of the pectoral nerve?
lateral,
See, it's an
clavicle
example.
part
Ah,
of
see. Now, put it. So the
clavicular part.
very simple to remember. This is the clavicle portion, which is lateral is the lateral portion of the pectoralis major.
Yes.
So lateral clavicle,
Clavicle.
medial
Sternal part.
So very easy to remember the anatomy. So now check for the lateral clavicle, the
90.
lateral pectoral. You can check which portion is working.
Sir, 90 degree abduction.
I'll hold.
Yes.
Okay. Check for the person. இந்த கையா உள்ள கொண்டுட்டு போகணும் யாரா சரியா
உலகணும்.
நான் பிடிச்சிக்க நீங்க ஃபீல் ஃபார் த கண்ட்ராக்ஷன் விட்டுருங்க கமான் மேன் கம் ப்ளீஸ் இந்த கைய உள்ள கொண்டு போ கீழே அழுத்தணும் மேக் இட் சவுண்ட் கண்ட்ராக்ஷன் which portion is contract ஏன் பணியை கழட்டிடலாமா So you can see on both sides, there's a dip. Okay, what does it shows? Wasting of the which portion of the pect? So this is a classical finding of missed in the inspection, right? So there's a gross wasting here. It takes you that the lateral pectoral is not working. It means that the lateral cord is not working. Understand? Then which is working? The sternum portion, that's the middle cord supplied by the middle pectoral. Okay. So now we'll have a quick mathematical workshop, right? It could be a posterior cord. How many states of posterior cord? Because the axillary is not working, triceps is not working, wrist drop. Can it be a posterior cord? Could be a posterior cord. Yes, keep it as an option. Could be a posterior cord. Can it be a lateral cord? Yes or no? Because the biceps is not working, lateral pectoral is not working, but lateral root of median is working. Does it ring a bell? Can this patient have a posterior cord, lateral cord? Yes or no? Does it ring a bell? Does it have any coherence with that? So this cannot be a lateral cord. Why? Because median was functioning. The low median was functioning, high median was functioning. Let's come to the middle cord. It could be a middle cord. Why? Because the ulnar nerve is functioning, median nerve is functioning, middle pectoral nerve is functioning. So now, all put together, you come to a diagnosis now. I told you a simple mantra C5, C6, C7. Okay. The rest of the portion, you have also checked C8, T1. You will keep us diagnosis C8, T1. If the examiner asks, can it be a posterior cord? Then we'll come to the sensory, right? See, this is all motor aspect. Now come and ask the sensory aspect. Check the sensory. In the book of Marathapur, you check for the dermatom. So the dermatom wise is that around the deltoid is C5 and come across over the extensor aspect C6, roughly around this portion C7, C8, T1, T1. Okay. எந்த போர்ஷன்ல எந்த பகுதியில் உங்களுக்கு மரமரன் இருக்குன்னு சொல்லணும். ஓகே. இங்க கிள்றது தொடுறதுலாம் மரமரன் இருக்கா? இருக்கு. இங்க தொடுறது மரமரன் இருக்கா? இருக்கு. தெரியல. இங்க தொடுறது நல்லா தெரியுதா? அந்த கை கப்பல். ரெண்டு ஒரே So, இந்த பக்கம் தொடுறது ஒரே மாதிரி இருக்கையா? ஒரே மாதிரி இருக்கு. இங்க ஒரே மாதிரி. So, what does this sensory aspect tell you? That dermatoma wise is C5 and C6 and the rest C7, C8, T1 is intact. So, these are all the sensory aspect which can also help sometimes if the motor examination is not taking you to diagnosis. Now, tell me your diagnosis. I say it's a 4-month-old post-traumatic right side brachial plexus. Okay, this much is sufficient. The other question is that whether it's pre-ganglionic or post-ganglionic. Now, if you can do this test, then your diagnosis is very clear.
Sir, check for serratus anterior. And
there are two tests which tells you it's a pre-ganglionic or post-ganglionic. So, what is pre-ganglionic?
Sir,
something. It is completely avulsed from the spinal cord. Very simple to understand. Something it is avulsed from the spinal cord. And post-ganglion is something after coming out of the spinal cord, the dorsal ganglion, after that it gets injured or ruptured. These are two things which can cause post-ganglion injury. Now tell me whether it is a pre-ganglionic or post-ganglionic.
Post-ganglion.
Sure.
Yes, sir.
Okay. So two things you understand. All pre-ganglionic injuries are nerve root injuries. They are C5, C6, C7. Or pre-ganglionic or or post-ganglionic or cord injuries. Either it be posterior cord, medial cord, or lateral cord. Now we are stuck up with the diagnosis. Whether it could be a posterior cord level injury or pre-ganglionic root level injury. There are two tests which can tell you it is only a purely pre-ganglionic injury. Do the two tests. I told you C5 is for shoulder, C6 for elbow, C7 for triceps. What are the things or what are the nerve roots which come from the root level?
Sir, long thoracic nerve
and
dorsal scapula.
Okay. If you can do these two tests and show that this is not working, it takes you to diagnose of
pre-ganglion.
And diagnose always root level. If these two things are working, okay, it takes you to cord level diagnosis. Understood? If these things are not working, then it comes down. So it's damn sure that's a
cord level.
Posterior cord injury, according to the finding.
Yes.
Now check these two things and you come to a diagnosis. Any questions so far? I've slowly taken you to diagnose between the cord level differentiation and differentiating between the preganglionic and postganglionic and coming to diagnosis. Okay. Check for there are two nerves which supplies two different muscles. One, the dorsal scapular nerve which supplies the rhomboids and levator scapulae, and the suprascapular nerve which supplies the supraspinatus and the infraspinatus. So if you can check these two muscles, if it is working, then you are very sure that it's at the cord level injury. Because below the cord, below the origin of the dorsal ganglia. If it's completely not working, it means that it's preganglionic. Definitely the root level, the diagnosis will be only at the root level. Any doubts? Understood? Then understood. Huh? Okay. Check for the two muscles. How do you check? Okay. So any கொஞ்சம் திருப்பிக்கலாமா? ஏன் நிக்க முடியாது? யாராவது ஷர்ட் போட சொல்லுங்க. ஏன் இந்த பக்கம் படுத்துக்கலாமா? இது படுக்கலாமா? ஏன் வாங்க படுங்க. உப்பரை படுத்துறீங்க. உப்பரை. நிக்கலாமா? Okay. So I'll tell you three simple things of understanding the scapula. If you understand what is scapula and the muscles, you will tell the diagnosis and you will tell the finding. So where is the rhomboid present? Okay, so rhomboid is on the medial side of the scapula border. Something like this muscle which originates from the posterior spinous process. So this is the rhomboidus muscle. So what does it do? It pulls the scapula towards the medial side. If it is not working, what will happen to the scapula? It will go down. Okay, this is the function of rhomboidus. The other thing, what happens if the trapezius is weakened? I'll tell you. This is the scapula. This is the trapezius muscle. What does it do?
Shutting off.
It pulls the scapula above. This is the function of trapezius. If this is not working, what happens? The scapula goes down. And these are all three different types of winging. You have to differentiate the examiner. This is the muscle which holds the scapula in this position. If this is not working, what happens to this? It will go up. Right? Because there is no muscle which to try to keep the shoulder here. Similarly, for serratus anterior, this is how the serratus anterior is oriented. So what does it do?
Protraction.
When it contracts, it keeps the shoulder here. It pulls the shoulder like this. When it doesn't contract, what happens?
Go for medial border become problem.
You tell me, this is the medial border. This is the serratus anterior, which is trying to keep the scapula in this position. This is not working. What happens?
Retracted.
What happens? This is not working.
Retracted.
It goes towards the lateral side. And also there will be, when you try to push the wall, what happens? This becomes more prominent. So winging of scapula is three different things. One, it could be because of on the medial side, the rhomboid is not working. So it becomes more prominent and becomes more medial side because it's trying to pull it. If this is not working, what happens? This definitely is the trapezius is not going to work. This scapula is always trying to go up. And this side, towards the direction of the trapezius. The serratus anterior is not working. The inferior angle doesn't have any control. This area will not have any control. This scapula completely wings like this. The inferior angle will turn towards the lateral side. The entire scapula will wing like this. Differentiate between three types of winging. This not working becomes more prominent. There's a hollow here. This inferior angle not working, it pulls the inferior angle towards this side and wings, and this is trapezius. Okay. So simple way of doing is, can you do on both sides the rhomboids? Sir.
Say trapezius is not acting. There is nothing to do the trapezius.
Yes, sir.
So it has come down or it will go up?
Sir, this portion of trapezius, It will come down, sir, because not pulling up. Yeah, pulling. Yeah. The attachment is something like this, it comes down.
Yeah, so if rhomboid is not acting, it is not going medially, so it is going lateral.
Yeah, it's going lateral.
So you are telling everything the other way.
Okay, the action, the function is something like, okay,
Yeah,
I'm sorry.
yeah.
The functioning I'm telling about, that's what I'll tell you again. See, this is the function of the rhomboids. It tries to keep towards the midline, right? If not working, what happens? Goes out. It tries to pull the scapula towards this side. Not working. This is serratus anterior. The inferior of the scapula is holding here, and the post of the scapula is holding here. If this is not working, what happens? This inferior angle goes this way, and this scapula comes to the towards the axle. These are three types of winging we are differentiate. If somebody asks you to examine, you tell them this is the function. If it's not working, this is what will happen. Understood? Because simply saying winging of scapula without understanding the anatomy will not make you to diagnose or will not help you to understand the pathology here. Okay, now demonstrate. Telling me.
நல்ல கை.
இப்போ இவன் கை இருக்குல்ல, இப்படி வெளியே தலை ட்ரை பண்ணும். ஓகே. So it is contracting on both sides. Here.
அடிப்பட்ட கையா.
Okay. So now do in this case. உட்காந்துக்கிறீங்களா? இதை படுக்க முடியுமா உங்களால? ஐயா படுக்க முடியுமா? நேரா படுக்க முடியுமா? இந்த பக்கம் புரியுதாப்பா? கைய பின்னாடி தள்ளணும். Feel for the contraction. Feel. கை இருக்குல்ல, பின்னாடி தள்ளலாம் போகும். ஓகே.
கையை தள்ளு.
இப்படி feel for the contraction.
Serratus anterior.
அதே மாதிரி அந்த பக்கம் பாருங்க.
அதே மாதிரி
செக் பண்ணலாம்.
எல்போட கையில் தான்.
நீங்க பிடிச்சிக்கலாம். You can hold it. You can hold it. You hold it. நேரா பாருங்க.
தள்ளுங்க, தள்ளுங்க, பின்னாடி தள்ளுங்க. பின்னாடி, முன்னாடி. உடம்பு.
Feel. தள்ளுங்க, தள்ளுங்க. It's always beautiful. Feel.
தள்ளுங்க கையை.
Okay. Feel.
Serratus.
So the rhomboid is working. So where are we now? We are not in the root level. We are trying to come down below the root level to the infraclavicular. Okay. So serratus anterior. So this patient cannot stand or cannot push the wall. One simple test which I demonstrated in any one volunteer, because none of the patient want to. Hey, you put up. Humorous. Any one volunteer so that it be easy for us. Because these patients can invariably have other fractures. You cannot ask them to push the test every time for doing the serratus anterior. One simple test which can do. Okay, sir. So he is a volunteer now. Because these patients cannot stand and cannot push the wall. So one simple test is that to ask this patient, you know that this is the area where serratus anterior is. From the chest ribs, it goes down to the inferior angle of the scapula and then also goes little posterior. This is the direction of serratus anterior. You stabilize the shoulder, ask this patient to lift and touch something there. அவ்வளவுதான். மேல தூக்கி அது தொடுற மாதிரி. அவ்வளவுதான். So you are stabilizing the shoulder. At the same time, you're feeling for the contraction. I could feel the contraction here. Feel the contraction. That direction. Feel. I also feel for the inferior angle scapula. This is how you need to do the test, because most patients cannot do a winging of scapula, because it's also vital to say that it's a pre-ganglionic or post-ganglionic. Now, you want to revise the diagnosis?
A case of 4-month-old, post-traumatic, post-ganglionic, extended upper.
See, one complete or partial. Now, you're sure that it's not a pre-ganglionic. If it's post-ganglionic, there are 3 parts you need to understand. One,
Upper
posterior cord, medial cord, lateral cord. If it's pre-ganglionic, root level. If it is C5, I told you C5 means shoulder is not working. C6 is elbow flexion is not there. C7 is elbow extension not there. And hand function. Now I'll tell you the diagnosis. You finally complete the diagnosis. He doesn't have pre-ganglionic injury because I checked 2 nerves which are from the pre-ganglionic or from the root level. They are the dorsal scapular nerves supplying the rhomboides major and rhomboides middle. And the serratus anterior is working. So my thought of diagnosing pre-ganglionic is not there based on my clinical finding. So therefore, I'm coming down to infraclavicular or post-ganglionic injuries, where I checked 3 cords. The lateral cord, the medial cord is intact, posterior cord, all these muscles are not working. Lateral cord, biceps is not working. And the lateral pectoral nerve is not working. Part of the lateral root of the median nerve is also working. So if you ask me, I'll tell you, this is a post-traumatic, post-ganglionic injury involving the posterior cord and the partial lateral cord. Yes. Any questions, any doubts? Why partially involving lateral cord? The muscular cutaneous nerve separated by the lateral cord is not working. There's wasting around the lateral pectoral nerve that supplies the clavicular portion of the pectoral major, but the lateral root of the median nerve has a portion which supplies the medial nerve, which is intact in this case. Therefore, I'm saying a partial injury. Can it be a C5, C6, C7, C8 injury?
No, sir. Finger movement, hand function.
So you can say that, sir,
Functions.
this patient doesn't fit to be a C5, C6, C7, C8 injury because these are all pre-ganglionic avulsion injuries where I've checked for 2 nerve roots which are working. So I'm trying to make my diagnosis as a post-ganglionic injury involving the posterior cord and a partial lateral. All right. Any questions? Any doubts? She says that's a recovering lateral cord. How do you argue?
No improvement in function.
So there's been this injury is there for 4 months and there's no history-wise, there's no improvement in the elbow function. And to corroborate your question, you can also say the examiner that I'll try to do an EMG NCV to see whether there's any re-innervation potentials happening around the biceps. Because by clinical examination, you cannot say. There's one simple clinical test which can guide you but cannot say that it's re-innervating, because all re-innervating muscles will have pain, muscle pain. Because the moment the re-innervation happens, more recruitment of motor unit potential is happening, it causes a muscle pain. We can do that. Yeah, it means that the muscle is completely wasted or paralyzed, doesn't have the potential for re-innervation. Okay, this is one simple test, a good question. You can convince the examiner that there's no muscle pain or signs of re-innervation. Okay, any other questions? What do you do?
like to do a electromyography and nerve condition studies.
So you have found something there, and what do you do?
Do a- Look for any regeneration.
You found
potential.
that there is a involvement involving the posterior guard, something lateral guard. What do you do? ஏன் உங்களுக்கு என்ன வேணும்? உங்களுக்கு இந்த கைக்கு என்ன வேணும்? நார்மலா வரணும். அப்புறம் கையெல்லாம் மேல தூக்கணும், மடக்கணும், அந்த மாதிரி வேலை செய்யும். What do you do for him?
Since 4 months duration, sir. And I prefer a nerve transfer.
So if you can say that I'll do a nerve transfer, that is more sufficient. I think that's what the examiner would not like to get the answer, apart from being an acute injury. Or say the maximum time where we prefer to hear the news of distal nerve transfers are approximately around 10 to 12 months, or the maximum 18 months where the neuromuscular degeneration happens. So that's the time limit we say that I'll do a distal nerve transfer. The most specific answers can be, you can study in your textbook. So the examiner would like to ask you, what do you do? I'll do a distal nerve transfer. You do explore the brachial plexus or not? I would explore the brachial plexus to confirm my diagnosis, to see where the lesion is happening. There are few chances that one or two, vesicles might be intact, one or two nerve roots might be intact, which you can see on stimulating neurostimulation that's happening around the tape during the operating. So this much is sufficient. Any questions? Sir,
Ask for an MRI or not?
would you ask for MRI or not?
Yes, sir.
Why MRI?
There are, we can see in preganglionic, we can see for pseudo meningocele, and if a nerve translated, we can appreciate.
So the MRI will help you in finding the pseudomeningocele if there is a rupture or avulsion from the spinal cord. We call as preganglionic avulsion injuries. So they all help you to diagnosing a preganglionic injury or a postganglionic. So MRI will definitely help you to say whether the brachial plexus is completely avulsed with the pseudomeningocele finding there. Apart from that, how does the MRI is going to help you? Okay, so I'll tell you. I've seen one patient who fell from the bike, and then he came to me. I have a video here. So all he can do except bending the elbow. So MRI helped us, and he had an acute disc because of post-traumatic acute disc. There's compressing the C6 roots. So you can say that, sir, I'll try to do an MRI of the cervical spine to also see whether there is any associated acute injury happening around the C5, C6 or C6, C7. So these are all things you need to find in an MRI. Okay. Anything else? Any questions? Sir, want to know what the difference between trunk lesions and cord lesions?
Sir, here suprascapular nerve and suprascapular nerve is not intact, sir. So suprascapular is in the trunk. So lesion might be proximal to it, sir. So maybe it is a trunk lesion.
So sir says that this could be a C8T1 trunk injury. How do you prove it? C5, C6, C7, C8T1. C5 and C6 forms the upper trunk or superior trunk. C7 forms the middle trunk. C8T1 forms the lower trunk. Sir says that it's a lower trunk injury, or says that C5, C6, C7 trunk injury. I mean, that's involvement of both upper and the middle trunk injury. Very simple. What are the branches given at the trunk level?
Anterior.
Two branches, suprascapular nerve. Have you checked the suprascapular nerve here?
Yes.
Show me the supraspinatus, infraspinatus. So what I tried to tell him what I tried to do. I'll tell you. See, the supraspinatus is the initiation of the abduction. This is the muscle which helps in the initiation of abduction. And sometimes even the supraspinatus muscle can forward flex and lift the shoulder even up to 90 degrees. That's a forward flexion. And an initiation of the abduction, they are supraspinatus. More commonly, when you check for supraspinatus, always keep the hand over the spinal scapula and feel for the contraction. Patient may not do this movement, but there will be definitely a contraction happening around the supraspinal. Okay, ஐயா முடிச்சுக்கிறேன். கையை மட்டும் தூக்க ட்ரை பண்ணு. சும்மா தூக்க ட்ரை பண்ணு. தூக்கு தூக்கு நல்லா feel for the contraction. Feeling for supraspinatus or trapezius? Okay, this is the spinal scapula. Feel for that. Ayya, tookuங்க. Okay, the other thing is that infraspinatus, because both are separated with suprascapular now. Infraspinatus is nothing but external rotation of the shoulder. ஐயா கையை வந்து உள்ள கொண்டுட்டு போகணும், வெளியே கொண்டு போகணும். உள்ள கொண்டு போங்க. ஓகே, வெளியே கொண்டு வாங்க. You feel for the contraction. இங்க வச்சுக்கிட்டு நான் பிடிச்சிக்கிறேன். வெளியே கொண்டு வாங்க. நல்ல வெளியே. வெளியே. இது உள்ள, இது வெளியே. ட்ரை பண்ணுங்க. வெளியே கொண்டு வாங்க. வெளியே கொண்டு வாங்க. வெளியே கொண்டு வாங்க. நான் பிடிச்சிக்கிறேன். இது உள்ள, இது வெளியே. ட்ரை பண்ணுங்க. சம்திங் நீங்க உள்ள கொண்டு போறீங்க, வெளியே கொண்டு இப்போ இந்த கை இருக்குல்ல, இத உள்ள கொண்டு போகணும், வெளியே கொண்டு வரணும். ஓகேவா? உள்ள கொண்டு போகணும், வெளியே கொண்டு வாங்க. ஓகே, வெளியே. ஓகே, வெளியே. It's partially working. So you can say that, sir, this supraspinatus, I couldn't do that, but infraspinatus is partly working, so it may not be a trunk level injury. Anything else? Any questions?
It should be for this, not trunk level lesion, it should be practically normally working.
It's working. It's working. The infraspinatus is working.
Possible be a trunk lesion. Yeah.
Very unusual, sir. Very unusual. Very unusual to have trunk lesion alone.
So it could be either be a posterior cord, recovering lateral cord, or it could be a upper trunk, under trunk lesion.
Upper and middle trunk, that be very remote possibilities.
So an MRI here will definitely help us.
Will definitely help us. Any questions?
There, Mike.
I think brachial plexus is very difficult to understand unless we know the anatomy. How many of you are very comfortable with the anatomy? Final year postgraduates தான் கை தூக்குங்க. MS of the final year. வேற ஒருத்தர் கூப்பிடலாமா brachial plexus anatomy? எல்லாம் கைக்கில
Sorry.
I don't know whether you've seen me or not. I went through the brachial plexus anatomy again. So brachial plexus anatomy, you have to be very familiar. Like Dr. Terence, if you are doing surgery on brachial plexus, you become very conversant. Otherwise, you have to go through the brachial plexus anatomy before you come to the exam. Because root, then trunk, then cords, then the nerves. Yeah. So if a simple algorithm is you test the nerves individually. And that patient, ulnar nerve was working, median nerve was working, radial nerve was not working. So it could be a radial nerve injury. Yes. Then you checked the axillary nerve. Axillary nerve is also not working. Then it is probably, it's not radial nerve injury. It is a posterior card injury. Yes. Now we moved up. We moved up from the nerve to the card. Then something is not right because musculocutaneous nerve is not also working. Musculocutaneous nerve is part of which trunk, which card? Lateral card. So it either is a.
Sorry to interrupt, sir.
Oh, sorry, Terence.
I request Professor Mohan Kumar sir to honor Dr. Terence. Thank you, sir.
Thank you, Terence, for making my life a lot easier now. Thank you. So it is posterior card plus musculocutaneous nerve. Musculocutaneous nerve is part of which card? Lateral card. So it is posterior card plus lateral card, or it may be something even higher. So for that, you need to know which nerve comes from the trunk, and the nerve which you tested is the suprascapular nerve. In suprascapular nerve, maybe we thinking he's not doing it well, or maybe it is involved, or he is not doing it because of wasting for prolonged period. So it is either a trunk, superior and middle trunk, not the inferior trunk, because C8, T1 are working. So it's a superior middle trunk or posterior and lateral card. So this is how we have to come to some working diagnosis. So I think somebody can examine this patient. You have elicited the history already. So briefly tell us the history.
A 35-year-old gentleman.
Stop.
Yeah. Good afternoon, sirs. He's a 35-year-old gentleman who's right hand dominant, who's a tailor by occupation. He came to the hospital with complaints of inability to use his left upper limb post trauma. So he had a trauma approximately 2.5 weeks back, wherein he had some injury around the arm. After which he had difficulty in using his entire upper limb. So he also had history of numbness and tingling sensation over the thumb and the index finger. So no history of any. So initially he went to outside hospital where they had applied a POP slab, and later he came to GH here, wherein they had treated him conservatively with a functional cast bracing and a dynamic cock-up splint, which he had while I was examining, sir, for the wrist deformity. No history of any trophic changes complained by the patient. No history of any constitutional symptoms like fever, loss of weight, loss of appetite, even increase of temperature. No significant family history. No other positive findings, sir. Yes, sir. So general examination.
Somebody go to not case hearing lens, so you can just go to the examination proper of each student. Your thoughts like follow the formula and go.
Examination of the
Circling that, we can talk.
examination of the left upper limb. So attitude of the patient. So the patient is on above elbow. The patient is on functional cast brace applied over the left upper arm with the elbows in flex position and forearm in mid-prone position with some amount of flexion deformity seen over the wrist and fingers. I don't find any obvious wasting over the forearm, and obviously arm I couldn't compare because of the applied cast. The examination of inspection proper. So
So now you've gone through the brachial plexus. Examine the median nerve and ulnar nerve. Okay,
yes, sir.
and find out where the deficit is in those three nerves. You have all had demonstration of all the tests, right? You just do it.
So palpation wise, there was no local warmth. There was
Nerve
diffuse
testing
tenderness of
better. Nerve
lateral
testing
nerves.
better.
So neurological examination, checking for the radial nerve. So the active movements were painful and restricted over the elbow, wrist and the fingers. But the passive movements were full and supple. So I was able to do the neurological examination. So the elbow extension, the patient was not able to because of the cast applied. The elbow flexion was not possible in forearm supinated position, but in pronated position, the power was 2/5 after eliminating the gravity, that is the action of brachioradialis. Then the wrist flexion, the power was
Exam பண்ணிட்டே காமிச்சு. Just show the test. நீங்க பேச வேண்டாம், just do the test.
அப்படியே மாதிரி வந்து கை வந்து உள்ளட்டும். For the brachioradialis, sir.
Fracture இருக்கலாம். Wrist ல.
Yes, sir. கை திருப்பி. சரி.
Radial nerve check பண்றீங்க முதல்ல. Just do the nerves individually, doctor.
Yes.
See, because you want to localize the lesion. Okay, do the radial nerve first.
மணிக்கட்ட மேல தூக்கு. திசை தூக்க முடியுதுங்களா? இப்படி வச்சுக்கோ. இப்ப வெளியில தள்ள முடியுங்களா? பண்ண முடியல.
So the finding is wrist drop.
Yes, sir. The power is 0/5.
Wrist dorsiflexion.
Wrist dorsiflexion is
0/5. Okay,
then checking for the finger extension.
Doctor, radial nerve. Sorry, finger extension.
இந்த விரல்ல வெள்ள இருக்கணும். இந்த விரல்ல இப்படி மடக்கணும். So
you're checking the finger extension of which joint?
Finger extension at the metacarpophalangeal joint.
MCK joint.
Okay. So I checked it with the finger flexed at PAP and DAP joint, so that only the external digitorum communis is acting there. So there is not even a flicker of movement in the.
So there is a finger drop.
Yes, sir. There is a finger.
Then third.
Then checking for the thumb extension, sir.
அந்த கையில விட்டு காமிச்சிட்டு இந்த see whenever you do the peripheral nerve examination, always teach the patient to do on the right good side so that he can do it for you. So do on the normal side. அப்ப அவருக்கு புரியும் இல்லையா?
அதே மாதிரி. So he is not able to.
So there is a thumb drop
extension.
So there is a radial nerve involvement. Radial nerve. Now check the ulnar and median.
Yes. So for the median nerve, I first check the.
Do the test. You don't have to talk theory. என்ன டெஸ்ட் பண்றீங்க, என்ன பண்ண சொல்றீங்க, அவரை வலது கையில பண்ணி சொல்ல காமிங்க.
So அது மாதிரி வந்து இந்த சைடு ட்ரை பண்ணுங்க. சரிங்களா?
So you're keeping all the fingers in extension and asking to flex only one finger. Okay.
மடக்கி வச்சுக்கோங்க. So checking for the flexor digitorum superficialis of middle finger, sir.
So is it normal?
Is it? Yes, sir. It is normal, sir.
So median nerve.
So median nerve is intact, sir.
Okay.
So next checking for the flexor digitorum profundus.
No. Finish the median nerve. That's one test for median nerve. Finish all the tests for median. Profundus, okay. Go on, yeah. So you're going to check the profundus of the index and middle finger.
Index and middle finger, sir. So the விரல் வந்து மடக்கணும். அதே மாதிரி இங்க ட்ரை பண்ணுங்க.
இப்படி stabilize.
Small doubts. So if we stabilize over the volar aspect, the tendon express will be.
Stabilize it PAP joint. இத மடக்குங்க விரல. மடக்கி பிடிச்சுக்குங்க. அந்த finger extend நீங்க பிளாக் பண்ணு. மடக்குங்க. அப்படியே பிடிச்சுக்குங்க. This is normal.
So stabilize behind Madaki.
So median nerve so far is intact. Any other test? Because every case you don't go with the idea it's brachial plexus. Because simple common things are common. Usually it is peripheral nerve injury you'll have in the exam and then brachial plexus. Go on, yeah, next. What are the tests for median nerve?
These were the tests for high median of palsy, that is.
No, keep doing the test, then you can narrow down the level.
The Arsenal class sign is negative, sir. So we
So
will not have
the
any-
pointing finger sign is negative. Okay. So what does it mean? That means the flexor digitorum
Flexor
superficialis
superficialis
and
and
profundus of the index finger is working well.
Absolutely.
That's why the finger is not kept in extension. So median nerve is again working. Any other test you do for median nerve? You have all demonstrated by Dr. Terrence. You just have to keep doing it.
கட்டவரில் வச்சு மேலே தொடங்கும் சரிங்க சொல்லுங்க அதே மாதிரி தொடங்கும் தொடங்கும் அப்படி வச்சுக்கிட்டு கட்டவரில் வச்சு மேலே தொடங்கி தொடங்கும்
பாயிண்ட் பண்ணி தொட்டின்னு டெஸ்ட் பண்ணுங்க. இப்படி காணும். இப்படி பேனா தொடுங்க. அதே போல இந்த பேனா தொடுங்க. பேனா தொடுங்க. கொஞ்சம் கஷ்டப்படுறாரு இல்ல? He's finding it some difficulty. So there is some weakness of the thumb reductor. Is there any wasting to go with it? Thinner area?
No, sir.
Not really. Yeah. Go on. Yeah.
No ape deformity. No ape appearance.
No ape thumb deformity. What does the ape thumb deformity mean?
Racing with thinner muscle cause flattening of the inner remnant. To the opposite side.
So what exactly is ape thumb trying to? So what does it mean ape thumb? How will it be?
So the thinner bulk will be.
So what's the ape thumb? Oh, anybody can talk on Saturday. Paswadi.
Normally, all the other metatarsals will be at different plane. Your thumb will be like if there is a weakness, all will come in the same place. What is the ape thumb?
So they are on the same line. It's not the wasting. Instead of the thumb separate from the other fingers, it's in the same line. Yeah. But that means the thinner muscles are not working. But here thinner muscles are partly working. Partly working. Go on here. Next.
That's one possibility.
This one. You had everything demonstrated, doctor. In an exam, you have to keep demonstrating. Because if you think of brachial plexus, it becomes very confusing. You think of median nerve, ulnar nerve, radial nerve. பேசிக்கிட்டே எக்ஸாமினேஷன்ல பேசிக்கிட்டே நீங்க சொன்னீங்கன்னு வச்சுக்கோங்களேன், எக்ஸாமினர் will be very confident. அந்த கையில காமிச்சிட்டீங்க.
Yes, sir. So he's able to flex his DA.
இந்த கையில இப்படி காமிங்க. ஓகே இப்படி. ஓகே இப்படி ரவுண்டா. அதே மாதிரி இந்த கையில இப்போ ஜஸ்ட் அப்படியே டைட்டா பிடிச்சுக்கங்க. Try to get your finger through. If he is not able to, he's got a normal. Is normal.
Yes,
so okay sign.
So
Is okay. Okay, go on, carry on. Next. So far median nerve you found it good except some weakness on the abduction. Okay, yeah. Okay, then you go for the ulnar nerve.
What is the test commonly done for ulnar nerve? One is your card test.
card test and the IGABA test for
Another is
dorsal plexus and the book test.
the book test. Yeah, that is very important.
So just keep doing it quickly because everybody is hungry. நல்லா டைட்டா பிடிச்சுக்கோங்க. அந்த பேப்பர் நம்ம மடிச்சுக்கோங்க. இன்னொரு மடி மடிச்சுக்கோங்க. It is actually called card test. So it has to be thick so that he can hold that. It's good.
அதுதான் வந்து லைட்டா பிடிச்சுக்கோங்க.
கையை நீங்க ஸ்டெபிலைஸ் பண்ணிக்கலாம், பிடிச்சிக்கலாம். இது கட்ட விரல
இல்ல
நீங்க
கீழே வச்சு நீட்டி வச்சு
இல்ல அந்த விரல வேணும், எல்லா விரலையும் சேர்த்து பிடிக்கணும். பிடிக்கிறாரு.
Yes, sir.
ஓகே.
Flexing and doing it.
He's flexing and doing it. So maybe there's some component, we do not know. Any other sign for ulnar?
The dots and key வந்து very
So you're checking for finger abduction
Finger abduction.
and adduction. How are they?
the weeks are
Slightly weak.
weak.
Okay. One more thing you can do on the motor on the ulnar. You can check for the flexor digitorum profundus of the little and ring finger on this side. Do the good side first and then the affected side. You can compare.
டைட்டா பிடிச்சுக்கோங்க அது மாதிரி வந்து இங்கே பண்ணணும் பண்ணுங்க அடக்கு
It's good, huh?
intact sir.
It's good. So far we have found the median nerve and ulnar nerve to be grossly normal. Yes?
Yes.
Just confirm the sensation of the median and ulnar nerve.
கண்ணை முடிக்கணும் ரெண்டு சைடு தொடர்றதும் ஒரே மாதிரி இருக்கா கம்மியா மரத்து பணமா இருக்குன்னு சொல்லிட்டு எப்படி இருக்கு தொடர்றது ரெண்டு சைடு சொல்றது ரெண்டு சைடு ஒரே மாதிரி இல்லையா திஸ் ஃபார் தி ulnar nerve. இப்போ ரெண்டு சைடு தொடர்றது எப்படி இருக்கு ஒரே மாதிரி இருக்கா மரத்து பணம் மரத்த மாதிரி எந்த சைடு மரத்து மாதிரி திருப்பிக்கோங்க கண்ணை முடிக்கோங்க இப்போ ரெண்டு சைடு தொடர்றது எப்படி இருக்கு மரத்த மாதிரி
So there is some numbness on the superficial branch of radial nerve distribution. Ulnar nerve and median nerve sensation.
Sir, but median nerve also is complaining of
Some disturbance on the median nerve side. Is consistent on all the fingers, 3.5 fingers, or
கண்ண முடிக்கும் இப்போ தொடர்றது எப்படி இருக்குங்க ஒரே மாதிரி இருக்கு
டார்சல் சைட் பாக்குறீங்களா எந்த சைட் பார்க்கணும் ஆக்சுவலா மீடியன் nerve ulnar nerve போலார் சைட் பாருங்க பால்மா சைடே பாருங்க டாக்டர் இந்த சைட் பாருங்க இந்த சைட் பாருங்க
கண்ண முடிக்கும் ரெண்டு சைடு தொடர்றது எப்படி இருக்குங்க
ஒன்னொன்னா தொட்டு காமிங்க டாக்டர்
ஒரே மாதிரி
சைமல்டேனியஸா தான் கஷ்டம் ஃபர்ஸ்ட் நார்மல் சைடு தொட்டுட்டு எப்படி இருக்கோ அதே மாதிரி இந்த சைடு கரெக்டா இருக்கான்னு கேளுங்க
அதே மாதிரி இது இருக்குங்க
So median nerve sensation is okay, doctor. So far we have narrowed down to a radial nerve. Yes. So it is difficult to check the biceps and brachialis, musculocutaneous nerve here. Axillary nerve is very difficult to check because he's got a POP. So we are not able to check whether it is higher than the radial nerve to posterior card. But looking at the patient's profile, he's probably had a fracture shaft of humerus, fits in for a radial nerve injury. So most probable diagnosis is a fracture shaft of humerus with a radial nerve injury, either a pre-op or post-op. Did you have surgery? No.
No, not
It is a pre-injury. It's a post-injury radial nerve. I think we can agree on that, can we?
Yes.
Yeah, we can move on. Okay, thank you very much. We'll go to this patient. Yeah. Histicating layer quick summarize பண்ணும் நெகட்டிவ் எல்லாம் சொல்லாதீங்க பாசிட்டிவ் மட்டும் சொல்லுங்க.
Good afternoon, sir. He's a patient by name Gopalan, aged 38 years, right hand dominant person, resident of the plumber by occupation and resident of Kundratur, Chennai. Came with the complaint of the deformity of the left hand over the little and ring finger since 1.5 months and altered sensation over the same part since the 1.5 month. Patient was apparently well 1 year back and he met with the road traffic accident, that is two-wheeler versus auto, and sustained injury to the lower limb and the elbow region. And following which went to taken to nearby hospitals, and after the regular investigations, the patient managed conservatively with oral analgesics and rest. And following which 2 weeks, patient able to do his daily activities. After 6 months, patient developed pain and swelling over the left elbow region over the anterior aspect. The pain was dull aching, non-radiating, and aggravated during these activities and relieved on taking rest and oral analgesics. And swelling was associated with swelling, which is aggravated during his day-to-day activities and relieved on taking rest. Following which patient went to the hospitals, and after the investigations, patient was mobilized with the plaster of Paris application for the 1 month in 2 settings. After 1 month, patient symptoms, pain and swelling was not relieved, and he went to another hospitals. And after the investigations, patient got operated, and after the surgery, operated 1 month back, and applied the immobilization for 10 days. Following the removal of the compressive cast, patient noticed deformity of the left index and left little and ring finger since 1.5 months, and which was that deformity was progressive and worsening in nature and associated with the altered sensation over the little and ring finger since 1.5 months. And patient not having any hypopigmented patches over the region and not having any neck pain and radiating pain. And past history was no. In personal history, patient not a known case of alcoholic and smoker, sir. No.
Okay, yeah. Do the examination.
After taking consent, sir, I explain the procedure. Patient examined in sitting positions. After taking consent and explaining the procedure, patient examined in sitting position, attitude, arm by the side, elbow in side flexion, and wrist in the flexion, and fingers at the flexions. And on inspections, there is
fingers விட்டுட்டீங்க.
fingers
முழுங்கிட்டீங்க.
flexions.
அதை compare அந்த side எப்படி இருக்கு, அந்த side எப்படி இருக்கு?
Sir, compared to the ulnar cuff, there is a significant flexion compared to the radial side. Little and ring finger in more flexions compared to the
So looks symmetrical to me. I know you have some positive findings on the ulnar side. To a casual examination, both sides seems to be symmetrical. Yeah. Okay.
On inspection, sir. On inspection, there's a scar of the tending to. There's a scar over the anterior and the medial aspect of the elbow region, and there's which is healed by the secondary intentions, and there's a wasting of the thenar and hypothenar eminence.
So there is wasting of thenar and hypothenar muscles. Sure. Huh?
Yes.
Okay.
And with
because whatever you say is going to bite back into diagnosis later. So if you say there's weakness of thenar muscles and hypothenar, you have to justify it later. Remember, because sometimes you know the diagnosis, you don't want to give findings which are not fitting for the diagnosis. And the examiner may catch you in that. Okay, go on.
There is a flattening of the arch of the metacarpal arch, and the dorsal aspect, there is a wasting of in the interosseous spaces.
So you looked at the back of the hand. It looks the metacarpals seem very prominent, suggesting there's a wasting of the intraosseous muscle. And generally, just like in the Dr. Terence mentioned about trophic ulcers, you also note for trophic changes. Go on, yeah.
And there is no sinus or research, but there's a decreased hair and the knuckle prominence over the left index and ring fingers.
So these are all the trophic changes. So hair changes are there. You can look for changes in the color. The hand may be shiny or it may be less shiny. The color may, if you look at the palmar aspect, it may be more red or less red, depending on the sympathetic involvement.
And nail, there's no nail changes.
No nail changes. Very good. Palpation. It's very important. In the inspection, you have to concentrate on the trophic changes. It tells us the duration or the chronicity of the problem.
Palpation, sir. There is no warmth, sir. But in palpation, there's a scar of the size of 10 cross 2 centimeters over the anterior aspect of the elbow, which is healed by the secondary intention, which is tender and not fixed, is mobile. Sir. And one more scar over the medial aspect of the elbow, which is 18 to 2 cross centimeters, which is non-tender and non-fixed. Sir. And
so for the purpose of the examination, you have to examine the elbow as a whole. So we are not going to do that. Summarize the elbow examination. Inspection, palpation, movement.
So elbow, that's only anterior, but there is a swelling is there.
Apart from the scar, did you find anything abnormal in the elbow examination?
Tenderness over the anterior aspects, the anterior cubital fossa.
Anterior joint.
Yes.
Okay then.
Okay. Movement, everything is normal.
So we will assume the elbow examination is normal, yes, apart from some tenderness.
Yes.
And the scar.
Yes.
Now we go into the peripheral nerve examination.
Yes. First one, motor examination.
Yeah, go on. Yes.
First,
நீங்க பண்ணலாம், யாராவது மைக் ஹோல்ட் பண்ணிக்கலாம். Whatever you do, you just keep talking and then demonstrate. You don't have to tell the theory because we have gone through the theory.
Examination for the flexor restored profundus.
So generally, when you do the peripheral nerve, you assume it is ulnar nerve problem. So you always check the nerves, normal nerves, and show to the examiner they are normal before you narrow down to the concerned nerve. So we assume the radial nerve and median nerve are normal, apart from your finding the thenar is wasted. So you just demonstrate the radial nerve and ulnar, median nerve first.
For radial nerve, there is a.
Normal கையில முதல்ல பண்ண சொன்னீங்கன்னா அவர் புரியும். Always in the exam, you just ask the patient normal side to do it, so it's easier to demonstrate. Resist பண்ணவே இல்லை நீங்க. Normal side resist பண்ணி, ஏன்னா you need to know the MRC grading as well. So you just say what the finding is when you do that. So you ask the patient to extend the wrist, and the power on the right side is 5, on the left side
Same, sir.
it's 5. Good.
And elbow flexion.
Just complete finger extension, thumb extension, just like what your colleague did here.
No, have you finished the radial now? You just sit there. There are few more tests for the radial now. No, you complete the whole radial now examination.
Wrist extension பண்ணீங்களா டாக்டர்? MCP extension, thumb extension, distal sensation, brachioradialis, triceps. அப்படி முடிச்சிருங்க.
Okay, we can ask them.
Go to the ulnar nerve. So you assume median and radial nerve are normal. Because நீங்க thenar wasting சொன்னீங்க இல்லையா? அது justify பண்ண முடியுமா தெரியல. இப்போ ulnar nerve test பண்ணுங்க.
First we examine from the proximal to distal. First check for the flexor distorum profundus. And we have to stabilize the distal intermental joint, and ask the patient to flex.
Of the which finger?
Ring and little and
you
ring.
have to do it profundus on the ring and little finger, because on that side is median nerve. So do that good side.
There's unable to do.
என்னாச்சு? எந்த இடத்துல வலிக்குதா? ஓ, விரல்ல வலிக்குதா? இந்த விரல்ல இது வலிக்குதா? இப்ப இந்த பிடிச்சிக்கலாம். நீங்க மட்டும் மடக்குங்க. மடக்கையில வலிக்குதா? வேற யாராச்சும் இது பண்ணி ஊறி விட்டாங்க. It's very sensitive. I understand. Okay. So you could demonstrate weakness of the profundus of the little and ring finger. Okay.
Flexor carpus.
Normal side மட்டும் நீங்க காமிச்சிருங்க, பெயின் இருக்கிறதுனால.
Ask the patient to fix flexion and flexion towards the ulnar side. And we have to palpate for the muscle contraction over the side. Right.
It's normal. In the side வந்து
Before that, anything for the hypothenar?
Next.
No, for the ulnar now, you said profundus.
Yes, sir. Flexor carpus.
Before that, anything for
hypothenar muscle.
little finger?
Abductor disc.
Proximal to distal வராரு, profundus பார்க்கறாரு.
Okay, fine.
FCU வந்துட்டாரு, இப்போ hypothenar வரும்.
Okay.
Next time going for abductor disc minimum.
அந்த நார்மல் சைடே காமிங்க, வலி சொல்றாரு. He is complaining of pain.
Okay.
Ignore that.
Over the index finger, over the hypothenar eminence, and over the thumb over the little fingers, and ask the patient to abduct, sir, to try to push the thumbs.
கட்டை விரல தள்ளுங்க, சின்ன விரலால. விரலால இப்படி ஓபன்
கொஞ்சம்
good. On this side it's weak.
Nice, sir.
This way we will ask because he's complaining of pain now. Okay. So the hypothenar muscles, the abductor digiti minimi is weak. So we have demonstrated profundus weakness.
Flexor carpus weakness.
So okay, then you just check the intraosseous
card test
on the right side alone.
Want to do card test?
Card test பண்ணுங்க. கிரெடிட் கார்டு வச்சிருக்கிறாரு. கார்ட் டெஸ்ட் நானே. So you did the card test on this side, it was weak. Okay. How do you test for the lumbricals? On the side like coming.
Sir, actually patient is genuine sign is this.
சரியா, அந்த கையில பண்ணி காமிங்க. Lumbricals எப்படி டெஸ்ட் பண்ணுவீங்கன்னு.
To maintain the intrinsic plus positions.
பண்ணி காமிங்க டாக்டர். கையை திருப்பிக்கிங்க, இப்படி திருப்பிக்கிங்க. So you want to stabilize the MCP joint in flexion. அப்புறம் அவர் வந்து என்ன பண்ண சொல்லணும்? You ask him to extend the finger with the MCP in flexion. MCP in flexionல வச்சு காமிங்க. மடக்குங்க, நீட்டுங்க. So on this side,
there is a weakness.
On which fingers?
Sir, the ulnar side.
Ulnar side.
No, sir, he is unable to extend circulation.
So he has,
Little and ring.
so is it intrinsic plus deformity or minus deformity?
Minus.
Intrinsic minus. Okay. So he's got an ulnar claw hand.
Yes.
So what is ulnar paradox?
Sir, usually whenever a lesion is higher, there will be more weakness compared to lower. But in ulnar,
Is lesion a high lesion or a low lesion?
high lesions.
High lesion. So you think it is probably at the level of the,
Sir?
at the level of the
Elbows.
elbow joint. What is the etiological diagnosis for this?
High ulnar injury mostly due to iatrogenic cause, sir. After the surgery, he developed the contracture in the.
So what surgery did they do? Do you know? We do not have the details.
According to history, sir, patient according to history, they told they had ligament and.
So they explored the ligament for repair,
Yes.
and then post-operatively he has this ulnar nerve symptoms and signs. I think we can conclude that we have examined 3 cases. One is a brachial plexus injury, another is a radial nerve injury, another is a ulnar nerve injury. So we've gone through all the peripheral nerve test. So make it very simple. Do the nerve test. So I will go through the algorithm again. In the brachial plexus, it can be very difficult. So start with the nerves first, median nerve, ulnar nerve, and radial nerve. If more than one nerve is involved, then it could be a multiple nerve injury, or try to see if the lesion is slightly more proximal. So in the first case, it was a radial nerve and musculocutaneous nerve. It is very difficult to injure these 2 nerves. So it most probably it is going slightly higher to the level of the cord or the trunk. If you find it is proximal to the cord, the suprascapular nerve is not working. If it is working, it is the level of the cord. You understand that? And if you want to go more proximal, you check the dorsal scapular and the nerve to serratus anterior, which are post-ganglionic. Okay, Horner syndrome is not there. This Horner syndrome is there, it is a preganglionic. So MRI is useful in preganglionic lesion. Peripheral nerve injuries, ulnar and median nerve, you should not fumble at all. You should be very fluent in examining in front of the examiner and just keep talking as you examine. Thank you. I hope you enjoyed the session.
Thank you, Dr. Chokalingam and Dr. Terence for taking us through all kind of nerve injuries. It's very tough for the exam. I think it will be useful for all of you. Next, after our lunch, we will be again having more feast for your brain with our beloved teacher, Professor Gordon has joined along with us. Welcome, sir. So we'll go for lunch now. Thanks, Dr. Singaradival, sir, Dr. Thomas, and Dr. Gopinath. They are kind enough to stay with us for another case. Thank you. We'll make it as quick again. We'll meet again at 2:20. 2:08 answer. 2:30, 2:30 we'll have. 2:30 we'll assemble. At least by 2:40 we'll start again. Okay, sir.
அவனை எடுக்க சொல்ல வேண்டியதுல அவன் எடுத்து எடுப்பான் அவன் புகை இப்போ போன் பண்ணல அப்போது இருந்து நாங்க சாப்பிட்டு வரலாம் இவன் கட்டிட்டு வரல
Welcome back, delegates. We are going to start up the session. Dr. Govardhan sir, Professor Gobinath Menon, Sigar Vadivelu sir, Mohan Kumar sir, presenter Dr. Akash. First 15 minutes he will be presenting, sir. First 15 minutes he will be presenting. You can ask questions with him. Next 15 minutes you can ask him to perform any test or his questions, anything. 10 minutes. Yes, sir. 10 minutes you have to, if you want to demonstrate any test to the students, you can tell, sir. 10 minutes only for discussion, management, investigation, management, what are the surgeries that you can start. 10 minutes questions from delegates. Thank you so much.
Yes. 9 years old, Master Badrinath, studying 4th standard, came with chief complaints of limping in the left lower limb for past 6 months, pain in the left joint.
Hey, you said Badrinath studying in 4th standard.
Yes, sir.
You didn't tell the age, doctor.
Nine.
What we are interested in, 9 he said, huh?
Pain in the left hip for past 6 months. Patient was apparently normal 6 months back. Had a history of fall from bicycle, following which patient was able to weight bear and do daily activities. Patient was able to do daily activities without discomfort, but was associated with a limp, which was noticed by his parents. Following after 3 weeks of the fall, patient developed pain on the left hip joint. Patient had a history of knee pain 7 months back, which was treated with the analgesics and topical ointments. Limp was increased in onset, gradually progressive, which was initially painful. Patient was able to do daily activities like running, climbing upstairs, up and down without difficulty. For the past 3 weeks, he has difficulty in these activities. He's an history of pain increased in onset, gradually progressive, which was mild in severity, now current of a moderate severity, intermittent in nature, dull aching type, aggravated on activities relieved by rest and medications, no history of referred pain, no history of radiating pain, no history of rest pain, no history of night cries and night pain. No history of fever, cough with expectoration, no history of loss of weight, loss of appetite, no history of other small joint involvements, no history of early morning stiffness, no history of burning micturition, no history of redness of the eyes.
So 6 months back, he had a fall. 1 month prior to that, he had pain in the knee.
Yes, sir.
Which was relieved.
Yes, sir.
Within few days. Okay.
That was before the fall.
Before the fall.
Before the fall. This 6 months ago, you thought that he had pain in the left knee.
Yes, sir.
Didn't it? He had pain in the left knee. 3 months ago, he had the fall.
6 months ago.
6 months ago. Oh. And you said about limitation of activity. What sort of limitation right now? Because you didn't describe. How severe it has become from the time? of the fall.
Able to walk up to only 100 meters.
The question is, you think the trauma was significant or not significant?
Not significant.
Not significant. Then why you thought it was? Means you mentioned that, that's why I'm asking.
At that time itself, he had a limp, but it was painless.
Prior to that, he had the pain, knee pain, and then the trauma didn't.
No. After the trauma, he said that he had a limp, but it was painless. And he started having pain after 3 weeks. 3 weeks.
Right.
So this is a significant limitation of activity. Don't just passingly say that. Okay. So initially you said that it was almost insignificant, painless. He had only limp. So progressively it has increased. So now you tell what is the activity limitation. Is he able to squat?
Yes, he is able to squat, but with difficulty.
And
sit in cross-leg position.
Is able to sit in cross leg.
Okay.
He's taking part in games, sports and all that. He's doing his normal activities.
So for past 6 months he was doing, sir. For past 3 weeks he has difficulty.
That's also important because it's not just sitting and squatting. Because he's at this age group, you expect him to play and do things. He's not doing all those things. Is he going to school?
Yes, sir.
He's going to school. Okay.
Because somehow you have to quantify what is the disability at present the patient is having. Okay, right. Next.
Past history, patient had no history of any surgery. Treatment history, patient went to a nearby hospital where they advised rest and analgesics, but patient didn't follow. Patient was continuously weight bearing for the past 6 months. Birth history, second born for continuous marriage, term delivery, full term cesarean section delivery, tried immediately after birth, no developmental delays, immunized up to age. Exam.
Right. So in your history, you are telling that there was no referred pain, no radiating pain.
But he said, there was pain in the knee.
So do you want to associate that knee pain with the hip pain or you don't want to? You want to associate. Then why do you want to mention that? No need to unnecessarily say some words which is against your own history. Okay. So that is one you should not have told. Okay.
Examination. General examination. Patient conscious oriented.
Anything significant?
No.
Yes.
Examination of patient lying supine. Head centered. Bilateral at same level.
In all children, you can tell the anthropometry, no? Height, upper segment, lower segment, arm span. You can tell that, in a child at least, right? If there's no problems, you tell anthropometry is normal. Okay.
Anthropometry normal. Examination of patient lying supine. Head centered.
Any generalized ligamentous laxity?
No, sir. No generalized laxity, sir.
Okay. You did the Beaton score?
Yes, sir.
Okay. Right. So these are some things which you are going to do different as compared to that of an adult, right? Okay.
Examination of patient lying supine. Head centered. Bilateral shoulder at same level. Exaggerated lumbar lordosis present.
Can you just keep the towel over the chest so that he'll feel little warm.
Want to come from the forehead to the hip or want to come from the hip to the foot?
Exaggerated lumbar lordosis present. Both anti-superior spine at same level. Attitude of left hip in neutral, knee extended, patella facing upward and outward. Foot and ankle in the position of ease. Lateral part of the foot touches the ground.
Which side is pathological?
Left.
Is the degree of rotation the same?
When you compare to the right leg. That's what you say. The lateral part of the foot touching the toes. So why do you want to say that? When you say attitude of the limb, hip is extended and externally rotated when compared to the right side. And then come to the knee and then, because where is the rotation taking place? In the hip joint. So this is more externally rotated, right? Tell that.
Right limb appears shorter than left limb appears shorter than the right limb. No obvious muscle wasting.
Yes.
Examination of the right, left hip. Inflection of anterior aspect. Examination lumbar lordosis is present. Both anti-sphenic spine at same.
You think there is no wasting? There is wasting on the vastus medialis. Okay.
Where will you expect the wasting more? If you have a hip disease, where you will expect the wasting to be more?
Medial side, medial, vastus medial.
They're the jaw muscles which move at that particular joint, isn't it? That's all. Now, if you have a knee problem, where will you expect the wasting to be there?
Proximal.
Quadriceps and the hamstring muscles. Similarly, in the hip, where will you expect more? You may have some wasting in the thigh. That's not a. You'll expect more wasting in the gluteal muscles and gluteal region, isn't it? Okay, so you may or may not have it.
Yes.
Yeah. Yeah, go ahead, talk.
Examination of left hip, inspection of anterior aspect. Examination lumbar lordosis is present. Both anti-sphenic spine same level. No visible swelling, scar, sinus, dilated veins over the anterior, lateral, and posterior aspect of it. Posterior aspect, gluteal muscle wasting present in the posterior aspect.
What did you say?
Gluteal muscle wasting present in the left side posterior aspect.
Yeah.
Hey, you went to the lateral side?
Yes, sir.
The lateral side, nothing? He said about that.
I didn't hear. I was not hearing.
No, you said from the front,
Front and
that side.
Lateral side.
Did you say anything about the trochanter and all that?
trochanter, no swelling is.
No swelling. Are you able to visualize the trochanter?
Trochanter is not visible.
Okay.
What is the still inspection?
Yeah, inspection.
You're done, front, side, then
Posterior.
Yeah.
posterior.
Gluteal muscle wasting present over the left side. No visible mass, scar, sinus, dilated veins in the posterior aspect. Palpation. Palpation of the no warmth. External lumbar lordosis is confirmed. Both anti-sphenic spine at same level. No warmth. Tendons present over the base of Karp's triangle. Bilateral femoral pulse felt equally. In lateral aspect, the trochanter is proximally migrated.
Is that
Tenderness? Yeah. Is there any tenderness in the hip joint?
Tenderness present over the base of Karp.
Tenderness.
Oh, because we didn't. Yeah.
Trochanter proximally migrated. Surface smooth. No thickening, no broadening. No paternal tenderness. Bitonal tenderness confined to the left.
There is no thickening of the trochanter, but it is migrated up.
Yes, sir.
When compared to the opposite side. Okay.
Okay.
Keep talking, keep talking.
Palpation of posterior aspect. No palpable mass. No posterior joint line tenderness. No tenderness of the posterior superior iliac spine.
Yes.
Movements.
Okay.
Deformities or movements. Which do you want to say first?
Deformities.
Why?
No,
Why do you want to say deformities first? Because you went to movements directly.
No, what they will say is here. Movements, they'll say, I'll describe the fixed deformities and then they'll go in for.
Anyway, the question is the deformity should be recognized before
First.
you start your movements, isn't it? Yeah.
Fixed flexion deformity of 15 flexion deformity of 15 degrees in the left hip. Further flexion up to 1.
Yes, sure.
Yep.
Okay, his consent is taken. That's what it right.
No, sir.
No, he's trying to lift up just to allow his fingers to go.
No, you have to lift up the thing, then that's not.
No, he's not trying to lift.
Patient is
The patient feeling
Patient
is
is
ticklish and then he is just trying to lift. So he was just
Relaxing.
Yeah, relaxing. Okay, do.
Able to pass insert the fingers beyond the spinous process.
Yes.
Flexing the normal hip up to the obliteration of. Here's the lumbar lordosis.
No, you can keep on tilting and then the pelvis is somewhere you'll get a flexion deformity. Okay. Yeah. Just demonstrate fixed flexion deformity.
So how far you are want to flex?
Where should this hand be?
So,
yeah. It's now your hand is stuck between the
Yes, sir.
spine and the pouch?
yes, sir.
Yes.
Where is the fixed flexion deformity of?
Now the spine is touching the finger or not?
Still not,
Not it, huh?
not it. It's touching.
Right, now the finger is, the spine is touching the
Fingers.
okay, fingers. Okay, yes. Okay, right.
Other flexion up to 120 degree, not associated with pain and crepitus.
Not associated with pain and spasm.
Yes.
Is there an axis deviation? You get, this is the right time to see that also.
Yes, sir.
There is?
Axis deviation.
Can you demonstrate it?
You show the normal side. So where is it going? You just tell.
Towards the same. Sure.
Okay.
Can you do it on this side? So why are you stabilizing that side? Why don't you stabilize the pelvis on this side? And don't hurt the child. Huh?
Okay.
Adduction of 0 to 20 degree, not associated with pain and crepitus. Abduction of 0 to 10 degrees.
0 to?
10 degrees.
10 degrees, huh? Sure. It's moving, is it?
Yes, sir.
Go ahead.
Adduction.
Okay. Right. Go ahead, talk. Keep talking.
There is no adduction.
You said how much is the abduction?
20.
10 degree you said.
You said this, nah, I'm holding it here. Yeah, this is this much. Okay, right. Then
How much is the adduction?
10 degrees. 0 to 10 degrees.
Adduction is also 10 degree, abduction 10 degree.
Abduction.
Okay.
Rotations, hip and extension, knee and extension, external rotation 0 to 70 degree, internal rotation restricted.
restriction is not a word you can use, doctor. You should give the degrees.
Not able.
There's no internal rotation. Is there fixed external rotation deformity?
Up to 0 degree, it's up to neutral.
It's coming up to neutral, but no internal rotation is possible. Which position did you see this?
Supine, hip and extension, knee and extension. Sir.
Did you see it in prone or supine? Which is the better position for you to see?
Prone.
Then you saw it in prone?
Yes, sir.
Okay. We see that.
Why don't you show us the prone position and find out?
Come the padapa.
I think this is the best opportunity to show that the gluteal muscle wasting, which is there. You can see that the normal side, you have got a nice, well-formed gluteal, whereas at the opposite side, it is.
Yeah, you can see it like that, you know. You can see the skyline view of the buttocks well, and that will tell you about the wasting. So show us how much rotations you say.
This is internal rotation. Very good. Okay.
Okay.
External rotation.
Comes up to neutral.
Just up.
This is rotating. Is there any rotation?
Yes, comes up to neutral.
Neutral. It's
Yeah.
not going for much of a, maybe a degree or two. Okay.
Just to see whether there is any external.
External rotation. Huh? This is internal rotation up to about nearly 0. External rotation is, this is the external rotation which is happening. Which is about?
That is also with a spasm. And
Yeah, pain. Not much of pain, or he's not mincing.
But he has got spasm.
Yeah. Now the question was, you said there's a fixed flexion deformity also, no? I'm not very convinced of the degree of thing.
There is no extension. There is no extension.
Measurements. Apparent shortening of 1 centimeter on the left side. True shortening of 1 centimeter. 1 centimeter.
Actually, one other movement which you should do in a child is a flexion in flexion of the hip and abduction of the hip combined, right? Did you look at that?
Did you do this? He was not there, probably examining the case when you were telling.
Yeah. So that's grossly restriction. No, you can see that.
Dr. Mohammed was demonstrating.
So you can see that in certain cases, say Perthes or a DDH, etc., you'll find it's grossly reduced. Okay. But all these are associated with some element of pain, isn't it? Okay, go ahead.
Apparent shorting of 1 centimeter in the left lower limb, true shorting of 1 centimeter, thigh circumference.
No, where is it confined? True shot.
Confined to the base of brain triangle.
Base
Left
of the
side.
brain strike. Yes. Supraorthocantry.
Thigh circumference was similar. Both thigh circumference is similar on both sides.
Okay.
Special test. Telescopy negative. Trendelenburg test positive. Hypocreated trochanter crosses beyond the Rayleigh line.
How much you said was the abduction adduction in the patient? How much was the abduction adduction in this?
Abduction up to 0 to 20 degrees.
Adduction?
0 to 10 degrees.
You think?
He said the abduction was only 10 degree. Now he is revealing 20 degree.
Okay, adduction is 10 degrees.
10 degrees.
Yeah. Can you rely so much on Trendelenburg? You said Trendelenburg is positive, huh?
Why don't you show us? How did you test them?
What about the other lines? They're all suggesting a shortening. Yeah? Okay. Can you do that?
Want to stand in the front or the back?
Yeah, why you want to have your hands? He is smart enough. He'll not. Hey, Nera Sirikira.
Guys, to make it stand normal first. Normal side. Understand what? First, normal.
Yeah, doctor, you're holding him also. He can stand. Okay. He can't take ages, but of course.
When is that? It's like normal, sir. Yes. Yeah, it is normal. Yes.
Down,
Okay. Ask him to spread both the arms so that he will balance. Okay. And then it's positive.
Yeah.
I will definitely not go for this test because there is limitation of the arc of adduction abduction.
See, you require about 15 to 20 degrees of free adduction available for the Trendelenburg to become positive, isn't it? That's why if you have a coronal plane deformity, means the relevance of a Trendelenburg becomes dicey, right? Okay.
But definitely you'll have to say, because there are examiners, even if there is fixed deformities, people ask.
Yeah.
So it is better to say if there is even 10 degree of movement coronal plane, you just say. But if the examiner starts asking, sir, the significance is.
No, you can always mention the Trendelenburg because some examiner is going to ask you why you didn't do the Trendelenburg.
Yeah.
So you might as well say Trendelenburg thing, but its relevance is not there because the adduction is limited. Or if there's a fixed abduction deformity or whatever deformity, right? So it's better you mention the word Trendelenburg because the examiner is waiting to hear that. Okay. Gate, you don't want to make him walk?
Poitu another poitu. Will run.
Yeah. Describe.
Bipedal, biphasic, unassisted, Trendelenburg.
No, you should see. When you see a gate, you should see from the front, you should see from behind and see from the sides. And describe the gate rather than putting a name or anything to that, right? Yeah, you should say, hey, Narendra, is it a painful gait or a painless gait?
Painless.
Painless gait. No. When you look at it from the sides, what you are seeing?
Shots.
Exaggerated lordosis. He's always walking with a
Exaggerated.
exaggerated lordosis, right? Okay. Then, when you see from the front, what is happening? ഒരു വാട്ടി കൂടെ നടന്നിട്ട് പാട് അങ്ങനത്തെ. Is there any drop? You think it's a Trenberg posture? I couldn't hear you.
Yes, sir.
You think it's Trenberg posture? But then it should not really drop, nah? With 10 degrees of movement available. So I would think it's always safer to say in the exam, describe the gait, all these things that you said, bipedal and all that. Describe the position of the head, the shoulders, the spine, the pelvis drop, the knee flexion, heel strike, all that you describe and then put a name. Sometimes you may not be able to put a name to it at all. That is there, then so it's okay. As long as the examiner knows that you have looked into all of this. Right? Okay. Then.
Not distal neurovascular deficit. No palpable nodes. Left knee joint normal, clinically normal. Sacroiliac joint clinically normal. Right hip and right knee joint clinically normal.
Spine?
No spine.
That's also important. Okay. And limb can be there because of a spinal pathology as well. Right. Okay.
Diagnosis.
Yes, go on.
Coxa of left hip.
Anatomical diagnosis, you want to put it as
Coxa
vara.
But you have to justify what.
Why do you want to say as coxa vara?
Restricted abduction and internal rotation.
Restricted abduction and
internal rotation.
Adduction?
Adduction also restricted.
Now, flexion?
Flexion up to 120 degree.
Extension is not there. So why did you say coxa vara? Shortening is there.
Shorter.
Supratrochanteric. Okay. So it's not arthritis. No, you're not putting arthritis or anything like that. Because earlier some person had put it that way.
Right trochanteric tendon.
No, but you also told that Scarpa's ankle
Tenderness.
that.
Yeah. You think it's arthritis? Now his abduction adduction is grossly reduced. Yeah. Internal rotation is not there at all. The limb, yeah, that's what he said. External rotation is not increased or anything like that. Extension is not there. So why you are not thinking in terms of that? Or could you?
Joint line tenderness, restriction of movement.
And 2 planes at least. Painful restriction of movement according to you.
And some of them are associated with
spasm. Muscle spasm. Could it be or could it not?
No. Why? Don't go into capital coxa vara, cervical coxa vara. No. So could it be arthritis or you want to still be in coxa vara? That is the only question.
In a plain coxa vara, you won't get all these. You will have only restriction of abduction and internal rotation. Free external rotation will be there. Free flexion will be there. There won't be any fixed flexion deformity in most of the occasion. That is why they are asking.
See,
And
if you think
also
it's if you are thinking of coxa vara as extra-articular condition, then these things definitely hold good. Do you think this coxa vara is due to an intra-articular condition? Is it?
There is some intra-articular conditions, isn't it?
Isn't it? Yeah. Otherwise, how will you expect these tenderness to be there, these movements to be restricted, axis deviation also you said. Yeah, so that suggests that there is probably a something may be there, isn't it? Axis deviation can occur even otherwise, this even without the child having a capital deformity or anything like that, because the internal rotation is not there. The limb is more or less although there's no fixed external rotation deformity, it is close to that. So any flexion is going to produce a obligatory axis deviation is likely to be there. But you can expect some femoral head changes also, isn't it? Yeah. So why you think it's only extra capsular or some cause of coxa. Is that the way it is? So you don't want to put arthritis, you would like to go for coxa. What is the cause etiology according to you?
What will you do for this disease?
Perthes. Age.
What is the one single finding which is against purpose?
Zero to 20 degree of abduction is possible.
You will always find trochanteric thickening. Did you find any trochanteric thickening? Then why are you going for purpose? How did you palpate trochanteric thickening? Just show us.
Normal side. Knee inflection and abduction. Probably along the shaft of the femur. Bony prominence. Trochanter. The lateral thickness of the trochanter.
Yeah, how do you look at thickening, doctor? It's a comparative or it's
comparative?
Do that. You hold it.
This small boy, no? You can hold it. Yes, you can palpate the anterior posterior borders with your.
That is how it should be. And so posteriorly, you should grab the trochanter. Find out that. And don't do any adduction. The tensor will become tight and you will not be able to do that.
Is it same or is it?
Same.
You feel it's the same. The child didn't have the gait was absolutely painless as far as you are concerned, isn't it, sir? So that's against an arthritis also, isn't it?
You are palpating here. The trochanter is at this level. It's not much of a trochanteric thickening.
Okay, so you think it's Perthes. Any differential diagnosis you want to take? Could it be infections or something like that? You said trauma. You gave some relevance to trauma.
Patient was able to engage immediately after.
So you don't think it's significant? Could it be infections of some nature?
Concentration.
That's history, examination wise. All movements restricted,
Not painful.
not very painful.
Not much of a muscle wasting for 6 months.
Yeah, if there's a 6 months old tuberculosis or something like that, there would have been a gross degree of wasting, painful, and the child is not treated, he's going to have severe pain, deformities, all that. So it's unlikely to be an infective cause. Okay. So you think most likely it is by exclusion you come to, but what do you want to do for this, sir?
Investigation.
What?
X-ray of bilateral hip.
What X-ray?
Pelvis, bilateral hip, AP and frog lateral.
You can take the frog lateral? Yeah, AP and frog lateral. Okay. X-ray?
Fine.
Read. Tell us the findings of the X-ray.
Capital. Femur epiphysis appears dense and covered on the opposite side. Centrons line intact. Reduced height on lateral side. Reduced height lateral.
Lateral?
Lateral height is reduced.
Lateral wall of what?
Epiphysis. Femoral epiphysis.
The entire size of the epiphysis you don't think is flattened out a little as compared to the opposite? Is the sclerosis the entire capital epiphysis or part of it?
Entire.
No, all that you have to say that, na? What about the neck? Is there any changing? Is there?
Broadening and
There's a broadening of the neck. Is there any brevia?
There are foreshortening of the neck.
shortened and broadened.
Yeah, all that you have to say. Yeah, what else? What about the, yeah?
Trochanterus proximally migrated.
Trochanter is proximately migrated. What about the changes in the acetabulum? Is there any changes in the acetabulum? Joint space?
How is the medial joint space when compared to the opposite side?
Is there, the capital epiphysis is contained within the acetabulum or not? All that you have to say, na? Yeah. So, what do you think? The acetabulum, there are any changes? What about the joint space?
Wide middle joints.
Wide and slightly, okay. Is the capital epiphysis within the acetabulum or is there something which has come out of it? Is there an extrusion, doctor? So, yeah, you can see that there is a, if you draw a line, how do you look for extrusion? If you draw a line from there, the capital, how much percent of capital femoral can be beyond it? Yeah, 10 to 12% or something can be there outside. Okay. But the shape of the capital epiphysis you change, I think has changed.
Flattened.
It's flattened. The height of the entire capital epiphysis is reduced. Yeah. Okay. So this is the AP view you think. Any more views are there?
Any other view?
Lateral view is there?
No, I think frog leg view he was asking for.
Oh, we have gone to a higher imaging.
Yes.
No, go back to. So what's your diagnosis?
Stage 1.
What?
Malformation stage 1.
So doctor, you'll have to give a differential diagnosis for a sclerotic capital epiphysis. That's what you're going to give, will it? So what are the other differential diagnoses other than Perthes? That's what you're trying to convey. What are the other differential diagnoses for a sclerotic capital epiphysis? Because X-ray is showing that only.
Yes, sir.
He said,
Yeah, what are the radiological pictures which can resemble this? Because you have to rule out those conditions before you say it's Perthes. Yeah? What are the other conditions?
somebody was telling pages.
Pages. Yeah, anyone? You can have? Any hematological disorders you can have? Sickle cell disease. Then what else? Dysplasias, okay. You can have metabolic diseases, gouters, storage disorders, right? All that can be a part of hypothyroidism. All these are features which give the appearance of a sclerotic capital epiphysis, right? It's not that all sclerotic epiphyses are Perthes. It's not true, right? So what do you want to do for this one? Let's presume that it's Perthes. What stage of disease?
Stage 1.
Stage 1. Stage 1, A, B.
A.
What is B?
Fragmentation.
Huh?
Subcontinental fragment.
Subcontinental? Yeah, tell. What are the stages you have in Perthes?
4 stages.
Yeah. Go ahead.
Initiation. Sclerotic stage. Fragmentation stage. Healing, reossification stage. Healing stage.
Okay. This is, you think it's a stage of avascular.
Yes.
What is 1A and 1B? What is 1A and 1B?
Early in late.
When there is no flattening, then it's 1A. If there's a flattening, then it becomes 1B, right? Okay, so this is 1A, 1B.
1B.
Yeah, it's probably going towards 1B. Is the entire capital epiphysis involved?
Yes, sir.
As far as the APV goes, the entire capital epiphysis. If you had a frog-like lateral, you would have known whether the anterior and posterior portion was also involved or not. Okay, right. Then
Head is contained within the structure.
you think head is contained. Okay.
traction to increase the range of movement.
So how do you plan? If you think it's worth it, what do you plan to do?
Traction for 2 weeks you want.
Traction
Traction for 2 weeks.
What is the purpose?
to increase the range of to reduce stiffness, reduce spasm.
To reduce spasm.
What else? What else you can do? 2 to 3 weeks it might take. That we agree it might take. Sometimes it might be taking longer. You might have to even immobilize for some time, right? In abduction. You might have to do an adductor
brace.
Tenotomy also sometimes if you don't get abduction. So you want good range of movements to be maintained. Nearly normal range of movements. Now flexion is there, extension is limited, abduction adduction is quite limited, isn't it? Okay. So you want to get range of movements. Fine. Okay, after 2 weeks, movement has improved. The child is range of movements is near normal. Then what will you do?
Bracing.
Bracing. Why you decide on bracing? You don't want to put any other classification beyond that? Will you put any other classification? Depending upon the collapse?
Lateral.
How many of you want to put a lateral classification? Yeah? I'm not able to hear you, sorry.
Caterpillar classification is for fragmentation stage.
Absolutely. Most of these classifications are used at the time of fragmentation. They are not very helpful for us, right? Even the Catral classification, even the lateral pillar at least early fragmentation. Catral and all that is late fragmentation. So they are really not useful to us in a stage of avascular necrosis. Yeah. You can only see whether the entire capital epiphyse is involved. You can look at the age of the child. All that can help you. Clear? Okay. So, what do you want to do now? You all know the lateral pillar classification, by the way? All of you are aware? Yes or no? Hey, come on. I'm also feeling sleepy, but we can talk. Yes or no? No? Yeah.
We'll ask you.
Okay, you tell us. Lateral pillar classification.
3 types. 4 modified as 3 types. No decrease in height.
What? Decrease of what height?
Lateral wall.
Lateral wall.
Lateral column.
What
Lat-
you need for lateral pillar classification? What is
Frog
the
lateral.
view?
Frog
Frog
lateral.
lateral. It is very difficult to tell with this view. What is the idea? Why are you doing frog lateral view?
What is the intention? Why your lateral pillar has been used?
It prevents the central. It acts as a weight bear.
Yeah, usually it's the first column which tends to fail, right? And the deformity which is going to occur, you can offset it at that stage, right? At least to some extent. Okay, so now this is, if this was a stage of fragmentation, then only you can use the lateral pillar classification. In this stage of avascular necrosis, is really not very useful to have. But definitely you should know in the exam. Okay, now what will you do other than the age you have taken? 9-year-old child, you want to put a bracing. Is it? After the range of movements have been achieved. Yeah, tell me the reason for that. How long will you brace him? How long will you think? Brace him? You know the natural course of the disease, how long will it take?
80.
Yeah, 1.5 years, 2 years, maybe even more. All that time you will keep him in brace.
Healings.
And healing only we are speaking about. Yeah? So really there's no real indication for the brace at this stage because he's a 9-year-old child. Now 9-year-old child, the years of available for remodeling is going to be reduced. If this was a 6-year-old child, remodeling will be good. 9-year-old, the remodeling is going to be poor. So you are going to be limited now. And secondly, you will be putting him in brace, not going for school, all social activities limited, everything will be a problem, right? You want to choose another option? Yeah, what is the other option you can do? Now that all the movements have been got back. Huh?
Surgical.
Any other method of containment? You want to contain only, na?
Surgical.
Say, doctor. What surgery? What surgery?
Varus derotation.
Varus derotation. Yeah, varus means actually you are abducting the hip. You want to see if the entire hip is going inside. You have to make sure there is no hinged abduction anywhere occurring, right? And then if it is the entire head is going in, then you will plan for a varus osteotomy. When you do a varus osteotomy, you are actually keeping the proximal fragment in abduction, ABD, right? Sometimes when you do an internal rotation, the capital epiphysis is better contained, right? So then you will do an internal rotation also. So you cannot just say varus internal rotation. It may or may not be required. Clear? Yeah, but you have to make sure the entire capital epiphysis is going into the acetabulum when you do that. For that, you may occasionally require a arthrogram as well. Clear? Okay. So you'll do a varus osteotomy, right? That's better because the hip will remain in abduction for the next 1.5 to 2 years. Clear?
Sir, shall we close? So you are doing very well both in the history and in the examination. Only thing what I would say is you are not confident. You are not telling complete sentences. All you knew the answers, but you are not speaking boldly. So everything you are doing well except the way you pronounced it. Okay? You be very bold. Did well. Doctor.
Before going for the next clinical presentation, it's a short panel case for the panel discussion. Dr. Amiravi is going to present the case.
Good afternoon, sirs. I'm here to present a case of a 22-year-old male. Patient has come to us with complaints of pain over the left hip and thigh for 2 months. Incidence in onset, gradually progressive, radiating to the knee. And there's no history of recent trauma, but patient has a long past history. So patient has had history of multiple fractures since the age of 9, and he has undergone native treatment for bilateral shaft of femurs. And again another episode of fracture for right femur, for which BDCP plating was done. And again he sustained a peri-implant femur fracture same side, and implant plate exit was done and femur nailing was done. And on the left side, patient sustained an ecofemur fracture, which was natively managed. So this was the history with which he presented to us. In 2022, 3 years back, patient came to us with difficulty in walking and diagnosed with non-union of neck of femur fracture with a shepherd crook deformity of the left femur. And patient was subjected to investigations to rule out metabolic and genetic diseases, and we were not able to conclude with that. And this was the radiograph image with which he presented to us. And patient was planned and taken up for valgus intertrochanteric osteotomy on the left side. And in 6 months follow-up, we found union was present, and patient was relieved of his symptoms, and he wanted to undergo surgery on the right opposite side also. So we proceeded with nail exit of the opposite side with valgus intertrochanteric osteotomy of the right side. And later patient was symptom free, but he went to another hospital elsewhere where he wanted a surgery to correct his limb length. And so he underwent a distal femur osteotomy and also implant exit of the left hip because they told that it has united. And later patient presented to us with the pain on the right thigh. And this was the X-ray he presented to us again. We found out that there was a supra-implant fracture above the distal femur plate. And later we did implant exit, and supracondylar retrograde femur nailing was done. And now patient has complaints over the left hip. And CT was done that shows there is a non-union in the neck of femur, which is still present. And again, in 2 months, patient has a stress fracture over the lateral aspect of proximal femur. So this is the X-ray at present, sirs.
So why was the left hip implant was removed?
Sir, that patient has done elsewhere. They've
No,
told.
they did only for the right side.
Yes, sir, but they've done the implant exit also because they found it was united and patient wanted to get the implant removed, sir.
So this surgery I did it with the left hip and right hip after he was very happy. So it was almost 7 and the first X-ray for me.
Yes.
So this is அதுக்கு முன்னாடி. So before.
You probably thought the left screw is penetrated, I think.
No, he was not having pain. So this was almost a reversed bowels with the bowels was reversed and he had so the bowels was almost 30, 100 and 120 degree bowels like, and he had multiple deformities. So this deformity was corrected and he was very, very happy. And he had a femur malunited and he had a cross retroversion. So almost 60, 70 degree. This I corrected with the trochanteric osteotomy and the reversion was also corrected. He became all right. Only thing he was persisting on lengthening. I said that lengthening would not be done. Just be with this and then we'll see. So with this I left. Now only I realized that, right. So his knee angle became, the HK axis became almost normal and he was doing well. He was walking. So this was not penetrating.
What was his metabolic reason, the diagnosis?
No, we screened only for the osteogenesis imperfecta and everything. The chromosomal pattern was normal. Otherwise, he was normal.
So
he
in upper limbs he's got a lot of.
He's not this person. This is not this person. So they just wanted to know what is the cause and how to manage. But I never realized this was the patient whom I operated. These two I operated and became all right. So with this, how can they remove the implant? I don't know. So next. So why did they do this? So this is the obvious stress fracture which is happening between two implants. Why this was removed? They have done some osteotomy. Why did they do this osteotomy?
Sir, for limb-length discrepancy correction, sir.
Limb-length discrepancy, how can they? Because it was already HKA was normal. Then why should they do something in the knee? Go back. So what was wrong with the knee to do a? Did he sustain any fracture for which he underwent?
No, sir. No, sir.
Shorten the knee.
They've done an osteotomy and did the plating. Shorten.
Shortening of
this. They wanted to equalize the limb, so they did a shortening.
Yes.
Probably. My God.
Because knee at the two different levels. So they have shortened it, they have done the
osteotomy. And next. So if they have done that in such a narrow zone, you have to bridge it with a fibular strut or an implant which crosses both. If it does not done, this is the problem that will happen. Because two stiff implants and in between an elastic bone with a small segment, this is bound to fail. So one day or the other.
So really it's okay. But this side is the problem.
So now he's come
Why
with a
did
left
they
hip
do
pain.
that other side?
No, now he's come with a left hip problem.
Left hip now he has got it.
He's not worried about the right.
Right is all right. Yeah.
His complaint is on the left side. It's pain, huh?
Yes, sir. It's pain.
So now it's showing arthritis probably early.
Now, do you have CT pictures of this left hip?
CT.
Sir, axial section showing non-union, sir. It's the axial.
Some more sections. Next is non-union.
Where section Ilya? Emma Pol.
Go back to the once he wants a totally different case.
So 22, sir.
22. Because still the
Have another valgus with osteotomy. Yes.
so another valgus which
That's our plan.
That's all.
No, the thing is, what is the cause of the pain actually? It's the
Next.
fracture. For that only you need to. So, and it's not because of
This fracture.
arthritis or anything like that.
No, sir, because this head and this, so much of cartilage is there, so both the AP and lat. Okay, so we have to do valgus osteotomy.
Yes.
So when you have to do, when you do this at this level itself, valgus and put in a good screw in the good place. And then, but you have to span,
Too many holes are there.
already it is there, so you have to span really long, biological. So go distal and put 3 screws. Distal to the distal most screw what we have put. So it should be site specific because our people can make even 20 hole THs with the straight plate. It may not work. So
Can we move on to the next case? Another one hip case. Adult hip case. Yes.
oh, yes,
Presenter Dr. Praveen Chandar from Stanley Medical College. I request Dr. Srinivasan to occupy the dais. From Omandurar Medical College.
Good afternoon, sir. Yes. Myself, Dr. Praveen Chandar. I'm from Government Stanley Medical College, final year postgraduate. My patient, a 48-year-old gentleman who is a painter by profession, from Chennai, came with complaints of limping for past 1.5 years and swelling over the left.
Sorry, you are not paying attention. Yeah.
Sir, 48-year-old gentleman who is a painter by profession came with complaints of limping for the past swelling over the left hip region for 1.5 years, sir. When elaborating the presenting complaints, the patient was apparently normal for 2 years back. Then he met with a road traffic accident. As per the informant, his patient's son, the patient had a loss of consciousness immediately after the accident, and he was carried to the hospital in 108 ambulance. On reaching the hospital, he was immediately intubated, and it was informed to the patient bystanders that the patient had a sustained injury to the head and left hip region and over the right leg regions. And after primary care, the patient got transferred to the neurosurgery ICU with Butenbar application on the left lower limb and a plaster application on the right lower limb. And he was on mechanical ventilation also. And he was there in neurosurgery ICU for 1 month. Not give any consent for a major hip surgery, but they eventually gave a consent for a surgery on the right leg. So a surgery was done on the right leg, and after that surgery, after 1 week, the patient was extubated, and he regained consciousness, and he got discharged. He got discharged from the hospital, advising non-weight bearing and bed rest for another 1 month. After 1 month of the home stay, the patient was started ambulating with support, and initially he had pain over the left hip region, but it was gradually subsided in the next 3 months duration. And after that, he could walk without any support, but there was a limping and a shortening of the lower limb. And patient also had a swelling. He noticed a swelling when he was started ambulating, which was painful and progressive initially, but what subsided in the next 3 months duration, and also the progression also stopped since then. Now, after 2 years of the trauma, the patient has a painless limb with and can ambulate without any support, and his day-to-day living activities such as sitting cross-legged and squatting and climbing stairs are affected, and he also having a painless swelling, which is non-progressive, and is at current size since past 18 months, and there is no similar swellings as well in the body. There's no history of any fever, cough, chills and trigger. There is no history of any loss of conscious, loss of appetite or loss of weight. There is no history of any other constitutional symptoms, sir. On past history, there is no history of any hypertension, diabetes mellitus, thyroid, COPD, drug allergy. He has a history of surgery on the right leg. Right leg.
Mentioned.
Yes, sir.
Now don't repeat the same thing. Yeah.
And no history of any tuberculosis or contact with non-tuberculosis patients. There is no history of any COVID-19 or contact with the non-COVID-19 patient. In personal history, he is taking mixed diet and he is a chronic alcohol since 18 years of age. And he's a chronic smoker since 18 years of age. And there is no significant family history, sir. On general examination. On general examination, the patient
What is his basic now problem that he is? He's going to work now?
Yes, sir.
He's a painter, you said, no?
Yes, sir.
He's going to back to his work?
Yes, sir.
Okay, he's not able to do a squatting or sitting cross.
Yes, sir.
Otherwise, he's a
And he has a difficulty while climbing stairs.
climbing stairs. Okay.
And
He's able to stand and work.
yes.
Is it?
Yes. On general examination,
Anything significant other than the head injury and all that? Anything significant? General examination which you want to tell us?
no, sir.
Nothing. Okay, come to the.
So general examination, there is a history of discharge from the right leg.
Okay, that you can tell on your examination. Okay.
On general examination, the patient is conscious.
Now he's conscious now. Anything else you want to tell us? Something different?
In general examination, no, sir.
General examination?
There is no
Come to the local exam.
Local examination. Patient was examined in standing and sitting and supine lying position. I would like to present the patient in a supine lying down position. The patient attitude, the hip at neutral, knee extended, and patella facing upwards, outwards, and laterally, but less compared with the right side, and angle at plantar flexion, and foot at ease, and less externally rotated when compared with the right foot. And there is no exaggerated lumbar lordosis. Both the anterior superior iliac spine at the same level. And on anterior aspect of the thigh, there is a swelling can be seen, which is diffuse and without any clear-cut margin. And see, so left.
Right.
It seems to be extended from anterior-medial aspect to the anterolateral aspect, and there is no sinuses, scars, or dilated veins present anteriorly. On lateral, there is a supratrochanteric halo seen, but it is at a higher level when compared with the normal side on the right side. And also there is a bony prominence seen at the great trochanteric region. Posteriorly, both the diploid venous is at the same level. There is no abnormal fullness or sinuses scars present on the posterior aspect. There is a beautiful asymmetry seen when compared with the normal side. And medial aspect, there is no swelling, scars, sinus present. On palpation, all the inspectory findings are confirmed in palpation. The palpation, there is no exaggerated lumbar lordosis. There is
inspection you didn't say about the lordosis?
Yes, sir. The anterior superior iliac spine at the same level. There is no warmth present on the anterior anterior joint area. There is no anterior joint line tenderness present. There is a swelling measuring about 4 into 4 centimeter in the Scarpa's triangle, which is diffuse without any clear-cut margin with surface irregular.
This one.
Nice. With surface irregular and without non-mobile and in hard inconsistency, and it's extending from anterior middle aspect towards the anterolateral aspect.
Yeah, so actually there's a loss of fullness. You know, there's a fullness there, isn't it? Normally it will be a little hollow. So this is definitely there's a fullness in the groin area. Right, okay.
Fullness in the Scarpa's.
Yeah.
And vascular sign of narrowing is negative, sir. There is a volume and character of the femoral pulse can be equally felt on the both sides when compared. And lateral aspect, There is no warmth present. There is no trochanteric tenderness. There is no bitrochanteric tenderness present.
Now, what is the characteristics of the trochanter?
Now, what is this mass?
Go again.
You said there's a swelling here. You just finished with the vascular. What about this swelling itself? You palpated that, no?
Yeah,
What is that swelling?
It's a diffuse swelling, sir.
Now, what is it? What is the consistency?
Hard in consistency.
Hard in consistency. Where is it arising from? What is the plane of that swelling?
Sir, the border lines are not palpable, sir.
Oh, yeah,
Accurately palpable, but I could palpate from the anteromedial aspect towards the anterolateral aspect of the thighs.
Yeah. Where is it attached? Is it in the femur or in the pelvis?
I think it's
How did you make out?
because of the
How would you make out if the swelling is attached to the femur or to the pelvis?
if it is in the
You said you cannot feel it well. That is, I can understand that. But how do you make out if the swelling is attached to the femur or the pelvis? What do you do if you want to know if it's a femoral swelling?
so we have to stabilize that to be relaxed. So if it is moving now, it is
Yeah, you'll rotate the femur. You'll rotate the femur and see if the swelling is moving. Is it moving? Did you look for it that way?
no, sir.
It's moving or not moving? Yeah, you just palpated. It's moving or not moving? It is moving definitely with the movement of the rotations of the femur. Is that?
Yes.
So where is this part? That's bony.
No, he feels it is not moving.
Oh, you feel it's not moving.
It's not moving.
Pardon?
Here.
No, here, this is the swelling you said, no?
Swelling is this much big. And it's very much closer to the operator parameter. Very difficult to say whether it is moving with the femur or not moving.
No, but rotations, I can see it. I can feel it there. Enna, valikida?
Valikida?
Okay.
I'm sorry. Okay.
Okay.
I think it is moving. I feel it is moving.
Yeah, it's a part of it.
கொஞ்சம் இப்படி திருப்புங்க பார்ப்போம். நீங்களே திருப்புங்க. இரு வேணாம். நானே திருப்புறேன். There is a, if I hold it, see that you hold this, then the trochanter moves differently. Come to side.
Okay.
Yeah.
If you catch hold of that swelling,
Trochanter moves.
trochanter goes independent.
Okay. Right. Like you, so where is the swelling according to you?
proximal femoral regions. Proximal femoral region.
Femur, is it attached to the femur or is it attached to the pelvis? That's the question.
Attached to the femur.
Femur. So that means movements of the femur should.
Rotation
produce
layer,
that-
idliya, sir.
No, no. If you hold it like that, you're still able to rotate the.
There is a gap between the trochanter and the swelling. Put your thumb there and then move the lower limbs. You will find that they are different.
Yeah. So you still, you think it's in the femur?
Yes.
Yeah?
Yes.
Okay. Right.
Okay.
Lateral aspect.
Interesting.
Lateral aspect. There is a.
It is a good finding that when you stabilize that portion of the bone and try to do the rotation, it is not transmitted to the swelling. No.
Lateral aspect, the greater trochanter seems to be elevated when compared with the right side.
Why
And,
seems to be? It is elevated.
It is elevated and with the regular surface broadening and thickening can be palpated. On posterior aspect, both the dimple of Venus are at the same level. There is no abnormal mass felt for the posterior aspect. There is no posterior joint lengthness present.
Yeah, go ahead.
And on measurements,
Movements and measurements.
Deformities, you want to say? Deformities, any fixed deformities, doctor?
No fixed.
It's not told the movements, yeah.
There is no fixed percent deformity present.
Hmm.
There is a flexion of active flexion of 60 degree percent.
It's
Without
got active flexion. He can do up to 60 degrees
yes,
of
sir,
flexion.
60 degree flexion without painless.
Madakya Raja.
And further active and passive.
இந்த கால் மடக்குங்க. சரி, அந்த கால் மடக்குங்க பார்க்கட்டும். இந்த கால் நீட்டி வைங்க. இந்த கால் நீட்டி வைங்க.
இதே தூக்க கூடாது மேல. ஜஸ்ட் மடக்கணும் அவ்வளவுதான். மடக்குங்க.
தூக்குங்க, முயற்சி பண்ணுங்க. 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 தூக்குறதுக்கு முயற்சி பண்ணுங்க. முயற்சி பண்ணுங்க.
Right.
That is that's separately.
Separate.
Yeah, go ahead.
Active movement of 60 degree without pain pleasant. Further active and passive movement is restricted, not possible. And also he has a extension of 5 degree pleasant, active extension of 5 degree without pain present. No further active and passive movement possible. There is a adduction of 30 degree pleasant, active adduction of 30 degree pleasant. There is no further adduction, active or passive adduction possible. There is an abduction of 5 degree percent. There is no active abduction of 5 degree, 10 degree percent. There is no further active or passive abduction possible.
What about rotations?
Rotations in extension and with the knee extension and knee flexion, the both internal rotation and external rotation are not possible. Only jog of movement.
No rotations are possible. Is the limb fixed in external rotation or how is it fixed?
Only jog can be.
Does it come to neutral, doctor?
No, sir.
Then limb is now facing outwards, na?
Yes.
It's remaining their way? It's not coming? கவுந்து படுக்க முடியுமா? குப்புறம் காட்டு. Yeah, go ahead. குப்புறம் படுத்துருங்க.
Measurements.
So you think there is no fixed deformity, but the rotations are coming only up to neutral. Is that what you're saying?
Yes.
No, that is not possible, no? Whatever you told. So the limb is in external rotation. Correct?
Yes.
But you say that there is no fixed deformity.
But no internal rotation also. This is not coming back to neutral at all. It is in.
Right.
And no further, not
Actually-
much of further external rotation also. So this is virtually fixed in external rotation actually. Right?
You could see that.
So the limb is lying in external rotation. And you're not able to bring it to neutral. Yeah,
Yes.
maybe a few degrees. That's all. Right. Go ahead.
On measurements.
Hmm.
There is a 6 centimeter apparent shortening present, sir.
நேரா படுத்துரு.
And
நேரா படுத்துரு.
there is a 6 centimeter through shortening present.
Okay.
And there is, and also 3 centimeter muscle wasting.
The shortening alone, where is the shortening?
Sir, femoral segments. Femoral segment, it is 6 centimeter shortening.
Where? So femoral supraspinal.
And with comparing the Brand's triangle, there is a 4 centimeter supratrochanteric shortenings.
So where is the other shortening?
I mean, inferior to the.
Infratrochanteric 2 centimeters,
2 centimeters.
supratrochanteric 4 centimeters, according to you.
Yes.
Yeah, so 6 centimeter shortening, 4 centimeters in the supratrochanteric area and 2 centimeters in the infratrochanteric area. Is that what you say?
Yes.
Right? Go ahead.
That trochanter itself is
Difficult to find. Whatever is identified as a trochanter, he has to tell that. What
Yes.
else to do?
Yeah.
It's difficult for him to localize. Yeah.
Sir, there is a 3 centimeter, 2.5 centimeter muscle wasting of thigh region and 2 centimeter muscle wasting present over the calf region, sir. An And an examination of the sir, gait, I mean.
Then after that, any movements, measurements, then
Yes, sir.
any other test
Nelson's
you-
line, the GT is above the Nelson lines.
Okay.
It's line. Shoemaker's line is
Says GTLT.
greater trochanter is above the Nelson's line, and Shoemaker's line is crossing opposite to the midline and inferior to the umbilicus, and Cheney's parallelogram is converging at the index side. And Morris bitrochantic, there is a 2.5 centimeter lengthening of Morris trochantic lengthening.
You mean the trochanter is
Yes.
shifted
Yes.
beyond by 2 centimeters
Yes.
on the left side?
Yes, sir.
Okay, then
Then the gates,
telescopy?
telescopic negatives.
Telescope is negative. இந்த கால் நேர தூக்குங்க சார் இந்த முட்டி மடக்காம இந்த கால் நேர தூக்கும் முட்டி தூக்கும் ரைட் கீழ் வைங்க இல்ல அது வேணாம்
Gates.
Trendelenburg gate, you want to Trendelenburg sign you want to say?
Trendelenburg sign is positive.
Trendelenburg sign is positive. Can you just show us?
So assisted Trendelenburg sign is positive.
Huh?
Assisted Trendelenburg sign is positive.
He could not stand on this leg?
Yes, sir.
Why?
He can stand, but he was not comfortable with that standing.
He's not able to balance himself.
Balance.
There's no neurovascular deficit otherwise?
No, sir.
Vascular also is not?
No, sir, no vascular.
Okay, just make him stand, make him walk also.
Breathing.
Spine is normal?
Yes, sir, spine.
He's not able to stand because of the right leg problem or the left side also?
He can stand, sir, but he was not comfortable with doing the Trendelenburg.
Sir,
So,
sir.
yes.
ஒத்த கால நிக்க முடியாது இல்ல உங்களால? How will you do a Trendelenburg in a patient with this much shortening? What should you do? Balance.
Assisted Trendelenburg.
Yeah, you can do that. But ideally, when you look at a Trendelenburg for the patient with a gross shortening, you have to correct the shortening. Probably put a couple of blocks below, make sure the shortening is equated, and then do the Trendelenburg. Right? So that will be the better way of doing a Trendelenburg in these patients. Because shortening is so much. Yeah. Okay. So you did an assisted.
Yes.
And what does it show?
Positive. It showed a dropping of the contralateral hemisphere.
Dropping. In an assisted Trendelenburg, you drop.
Sir, it's, he put a pressure on my left palms.
Okay. Ask him to walk. Yeah, describe his gait. Describe his gait. Don't make him walk for too long.
Sir, biphasic, bipedal, unaided, short limb gaits.
Short limb gait. Why you said short limb?
Sir, because he is
Why in your description you said it's short?
Because shoulder is drooping the same side.
No, shoulder is dropping on that side, the knee
And the
is
knee
flexed on the
flexed
other
on the
side.
side.
All that suggests that he's trying to equate the limb length.
So both shoulders dip together when he puts the stance face on the shortened limb, and the stance face, the normal side or the longer limb side, it never goes in for full extension. Okay.
Is it painful?
No, sir.
No. Okay, right.
Yep.
Yeah.
Sir, a 48-year-old gentleman with coxa due to post-traumatic sequelae, most probably because of the malunited proximal femoral region fractures. Malunited fracture of proximal femoral region with
What produces so much shortening? 6 centimeters of shortening.
My differentials.
And there's a mass which you said is there in the front also,
Yes.
which you are not included in your diagnosis.
Yes. Probably because of malunited fracture of the proximal femoral region with internotation deformity abduction restriction.
No. Don't put everything in your diagnosis. Diagnosis is malunited proximal femur fracture.
What are the possibilities of this mass there? You think it's because of malunion alone?
No, sir. It's because of it might be because of consolidation.
No, but if a patient with a head injury been in the ICU for so long, what are the other things you can think of?
Heterotrophic.
Yeah.
Heterotrophic ossification.
Yeah, so you won't think about that. So that should be a part of your diagnosis, na?
Yes.
Yeah.
So what is the point against heterotophic ossification?
Yeah.
Sir,
Which muscle will have the heterotophic ossification?
Sorry.
In
Usually
the hip.
around
Anybody in the crowd? It is usually the iliopsoas. So it will be spanning between the pubic bone to its lesser trochanter region. So you will not have much movement in the hip.
So
This fellow has got so much of movement.
Yeah, it will be an ankylosed hip virtually, isn't it? Yeah, know the classification which is used also, isn't it? What is the classification used for a heterotrophic ossification on the hip? Brooks classification, yeah?
Yes.
Okay, anyway, that's beside the point. But you should keep in mind that this mass could be a myositis mass as well, isn't it? Yeah, right.
Any other possibility which you can think in terms of
So it could be
the mass?
it could be a tumor also, sir. But post-traumatic sequelae here it is post-trauma.
Not audible.
Sir, it could be a swelling due to tumor, sir.
Tumor. Which tumor?
Sir.
Pre-existing tumor.
Pre-existing tumor.
That trauma. Anything which you can relate to trauma.
Sir, anterior hip dislocations.
Anterior hip dislocation with fractured neck causing this. Quite a good thinking. Okay. It is quite possible that you may have an anterior dislocation of the hip with a trochanteric fracture with overriding. Another possibility you can think of. One possibility which we thought of is a heterotophic ossification. The other possibility is this. Any other possibility? I thought the first possibility is my diagnosis. So what would you like to do?
So I would like to do a radiograph to confirm my diagnosis, sir.
X-ray of Ramesh, yes.
Come on. It belonging to this patient?
No.
You have seen the X-ray? X-ray for
Patient choose after seeing the X-ray, isn't it?
Making us more anxious.
Everyone other than everything except the X-rays, patients, delegates.
Praveen. Chandra Shah.
It is opening the away, it's not opening the.
Oh.
One minute, sir. திரும்ப ஒரு தடவை note பண்ணணும்.
Any doubts? Anybody having?
Following this discussion, there will be a lecture on orthotics and prosthetics. Next, small short cases will be accommodated tomorrow's session. So following completion, after the completion of this case, a lecture will be on orthotics and prosthetics, following which a quiz and tea break. With that, we are closing the session. 2 short cases will be added up with the Sunday session. Thank you.
எக்ஸ்ட்ரா இருக்கும் பின்னமா இல்ல
அப்படியே காமிப்பா மொபைல்ல
you can use it in front of the
Hand session.
சரி ஹாட்
1 minute.
ஏதாவது மெயில் வாட்ஸ்அப் ஏதாவது
We will try to accommodate the hand session tomorrow. Tomorrow will be packed with short cases. Okay.
Monday we can do it. Yeah, Monday we should
பக்கத்துல ஒரு சின்ன சந்தி மாதிரி போயிட்டு அதையும் தாண்டி கொஞ்சம் மேல zoom பண்ணி so head is inside. You have a CT picture.
Any CT scan? CT is there?
So only X-ray.
Only X-ray.
Oh. So what do you want to do? What is his? You have to see the X-ray. What is your diagnosis?
Sir, malunited subtrochanteric fractures.
Badly shattered trochanter
subtrochanteric region, isn't it? Head is inside. I was thinking the head is out, but the head is inside, and whatever the mass which we are palpating was happening on the medial side of the shaft of the femur. And what we thought is the greater trochanter was the subtrochanteric femur, which we were thinking. Okay. So you need to do a CT, 3D CT, and find out what is the shape of the upper end of the femur. Otherwise, this fellow is walking well. So what is his requirement?
Sir, he is completely pain-free, sir. His only complaint is short limbs.
Okay.
Short and
So what do you want?
Sir, I would recommend a heel raise.
You want to give a heel sole rise for 6 centimeters?
6 centimeters.
6 centimeters is too long, you know. He is comfortable, do a lengthening in the lower level. Unless otherwise you want to do a complicated procedure there, simple procedure for a patient who is not very much bothered about this, he want a limb lengthening. You do a 4 centimeter lengthening, he'll be very happy.
Yeah, then 2.5 outside the shoe, it is not possible. 1 to 2 again inside, anything doesn't. More than that, you cannot give a heel and sole rise. Don't say.
Yeah, for 6 centimeters is too much, right? You can reduce the limb length discrepancy by, if he's willing for surgery, a limb lengthening procedure.
But don't do the shortening of them.
So a limb lengthening procedure probably below the knee, which will be easier for us as if he's okay, because the femur itself, you don't want to do anything much. Yeah?
Yes.
Dr. Sriram was there. At that time, we had a similar problem where the patient came with shortening of 4 centimeters with overriding of the femoral shaft fracture. Then he was thinking whether we can do the osteoclasis, give a traction, things like that. And then the other day he came and said, we will lengthen him. He put an orthofix, we lengthened him. We didn't bother to do anything with the malunited portion, which was rotationally is all right. Only overriding was there. So that fellow happily had a lengthening of 4 centimeters, which was a short. So similarly, you can do that in this particular case. No, don't know. I don't know.
That'd be a adventure. Maybe a misadventure also. Yeah, and probably if you do the femur, you don't know, there might be some degree of union also, you're not too sure actually in that area, right? Because you could feel the mass moving a little differently and all that. So unless a CT scan is done, you really cannot assess it. So you do not touch the femur at all. When you want to do a lengthening, you do it on the tibia, the knees will be at different levels, but that doesn't make a big difference, I think, in his case. Yeah.
I request Professor Tolkapian sir to present a memento to Dr. Govardhan sir.
Thank you.
I request sir to give a memento to Professor Srinivasan. I request Professor Tirunavukar sir for his lecture for orthotics and prosthetics.
So very good afternoon to Honda here. After the hectic next slide. Next slide. After the hectic morning complete schedule of academic clinical teaching, kind of relaxing for some time to get into the what are the common things that you come across in a regular day-to-day clinical outpatient, the topics that you come up. These are the things that briefly I will go to talk about. The topic is on brief of types of orthotics and some components of the upper limb orthotics. The brief of what is the common thing you come across, the spinal cord injury, what is the orthotic that you use the common spinal cord injury, and a brief about the prosthetic. So let's hope that they'll be able to have some brief of knowledge input to all of you. Next slide. So it's a externally applied device used to modify the structural or functional characteristics of a neuromusculoskeletal system. That is the definition of orthosis. International Standard Organization 1987 has defined various characteristics, what are the how should be the nomenclature, all other related issues have been defined by particular era, time. Orthotic meaning to correct. These are other terminology that should be aware of you. Next line. So basically, have some mechanism. How does it work? The orthosis, how does these are things that should be. It's a simple reminder. So cervical does not give much of your immobilization. Just tells I have some issue that you have to take care of a neck. Of course, spinal orthosis talus raised reduces the range of motion, avoiding the pain in case of fractures or unstable fractures. In total contact, where this present day A4, thermoplasty A4 gives all support, so they're able to transfer the weight and able to reproduce function. The next topic that Pascal's law 3.1 are the basic of the principles behind the orthosis. Next slide. This is a simple 3-point pressure principle where the load, as you can see, maximum angle where the load that the deformity is given one pressure, the other two pressures are given there. So making this is a very simple mechanism. 3-point pressure principle. So that should be all aware of it. F1 should be equal to F2 plus F3. There, yeah. So this is a basics of any orthotic principle that we come across. Next slide. What is this hydraulic mechanism? So every pressure where there's been transferred from one part in the hydraulic system, automatically the pressure is transferred to the opposite side. This is a simple hydraulic mechanism. The abdomen is one of the hydraulic mechanisms where the pressure you given in the abdomen automatically transferred to the anterior part of the spine. So it gives some kind of a support. So this is one of the simple mechanism LS will gives a support to the spine. Next slide. What are the objectives? This suggests to support in case of an injury, aligned to maintain the normal back mechanics, simple OAS spin. Sometimes we do have an osteoarthritis where you have normal back mechanics and you get preserved. To relieve the pain, maintain the deformity or correct the deformity in case of scoliosis, and even preventing the complications in case of a. These are some of the objectives of the orthosis. Next. So some types, basic types. There is static and dynamic. There is statics, no movement, dynamic, that's a functional movement. So these are the basics of every orthosis, all of you be aware of it. Simple static capsuling, there is everybody is aware of a static principle, that is a static orthosis. When dynamism is where you are able to maintain a function and able to avoid complications like in capsulant. And turnbuckle orthosis is the turnbuckle orthosis where we are using in Kirpak Medical College where the burns department was there, where the deformity is burns. So soft tissue deformity, this is like Elizabeth principle, there's a unit here, the unit here, there's things connected, every can turn around. So it takes a dynamic kind of a static progressive orthosis, there's a turnbuckle orthosis. The soft tissue is a major problem of the contracture, here the problem. And serial static, where the orthosis is worn for some time, getting correction, again redo it again, another new position. So they can serially work study to correct this. These are the various types of the orthosis that we can replace in our clinical practice. Next. Naming. How do you name the orthosis? How do the nomenclature? Say suddenly you get Cockup's splint, foot drop splint. These are the correct nomenclature that has to be followed. No, this is basically as per the ISPO guidelines. Name is based on the joints they cross. The simple basic that you should be aware of it. Another classification, other naming should be whether it's static or dynamic. Finger orthosis crosses a joint, finger joint. You can see WHO, your Cockupson should be called as a WHO, wrist and orthosis. So like that, the number of joints it crosses can be taken. So this is how the actual nomenclature. So this gives a clear direction to the orthotist who fabricates it, what type of an orthosis that you want to fabricate. And this nomenclature is very important, whether he has to cross the joint, it shouldn't be crossing the joint. So that's a very universal nomenclature that has been followed up. Next. Next slide. Coming to the very basics, radial nerve palsy, the Cockup's is a wrist drop, thumb drop, or finger drop. What is the major problem is when the drop is there, the length tension relationship of muscle is lost. So this is here where you get a flexion contracture of the left alone that has to be prevented, and unopposed action of the flexion should be maintained. But at the same time, when the nerve is recovering, the muscles, the dorsum of the muscle should not go for lengthened. So the length of the muscle has to be maintained. This is the basics of it. So your splinting should be able to maintain the normalcy of the extensor group so that when the muscle recovers, you should be able to take it up and should avoid the contracture and should be. This is the basic. So what do you do? Next. Static Cockup's splint. This is the terminology. What you have to maintain the length tension relationship of the muscle has to be maintained. So the extensor group of muscles is maintained. And the unopposed action of the flexor also maintained. So that's a dynamic Cockup's splint, where here the static Cockup's splint that you are to maintaining the extensor group muscle, but no dynamic action of the flexor. So this is the simple basics of any Cockup's splint and dynamic Cockup's splint. Next slide. Everybody aware of the claw hand, total claw hand and partial claw hand. Partial hand is run-on of palsy, and the total claw hand is both median and run-on of palsy. Intrinsic minus deformity minus. So what is the next slide? So what is the nerve involved? Both median and ulnar nerves involved. What is the muscles paralyzed? Lumbricals and intraosteal. So what is the function of lumbar? Intrinsic plus position, intrinsic minus position. This should be very, very basics. Intrinsic plus position, this is intrinsic plus position because lumbricals produces MCP flexion, IP extension. Intrinsic minus position, that means intrinsics are not working. So this goes up like this. So this is a claw hand. So MCP goes into hyper extension. Why? Because your MCP flexion is not absent because lumbricals is paralyzed. Your unopposed action of the extensor digitorum takes the MCP dorsiflexion. So what happens here? IP extension is gone. So unopposed action of the long flexors. So this is a classical problem in the case of a total claw hand. What is the problem with the claw hand? Next slide. The function. Last slide. Next. So for any functional hand position, MCP flexion is essential. So MCP flexion, we cannot do that. So when you cannot take any object with this MCP in extension, so you should do the function. So what knuckle is bent. So you have to make bend the knuckle position and IP extension has to be there. This is MCP has to be flexed. That is the requirement. So next slide. In a case of simple claw hand, you just put a bent position to the proximal flanks of the ring finger and finger, automatically the link will go for extension. That relieves the problem of MCP. When you make MCP flexion, automatically get the IP extension there. But when you come to law, when you come next slide, when you come to combined palsy, so what you have to produce is knuckle bender splint. So two problem okay, one problem, you are bending the knuckle, so you are able to get the fend position. So what is that position? What you have to get it? You have to get the IP extension. Now we are getting the IP extension. Lumbricus is MCP flexion. IP extension intra-same. So bending the knuckle position, you are getting the one problem of the solved. So how to get the IP extension? So because IP extension you have to release it, isn't it? So that's where your next slide. Next slide, you are using the role of extensor expansions coming into role. Because extensor expansion is there is your extensor tendon extended through the middle slip. You can see that the middle slip getting inserted into the middle flanks and these two laterals getting as a terminal slip. You've been all of you aware of this basics of extensor expansion. So this extensor function, which is unopposed extensor functions, is supplied by the radial now in a flexed position. This force will be transferred to the extensor expansion and through the IP joints. So this is how the IP joints are getting extended. So this is a fundamental functioning of a knuckle bender splint. The mechanical position of knuckles bent by the splint, but unopposed action of the extensor digitorum, which is supplied by the radial extensor IP joint. So you will get the lost function restored here. Okay, next slide. These are completions here. So this is one of the first web space is gone because of the head thumb deformity. You have to maintain the web space. This is a simple thumb space. This is called opponent split or short opponent split or long opponent split depending upon the joint that crosses. Next slide. This is one of the old time Brown splint used for your CTV, congenital talipes equinox. These are the clubfoot. Those days that we have been manufacturing in our institute, but present day we got next slide. All ready-made designs are available. Looking at all the three components, equinox component, 9-foot varus component, 4-foot varus component, producing all the necessary straps available, so that once the position of the clubfoot is correct, case can be maintained by the customized, even ready-made authors of various designs are available. So this is a clubfoot correction splint. The next. Actually, the old timers, those days, these are the conventional orthoses. Very, very conventional. With those days, we call this is a stirrup, and this is a thigh band, this is a boot. This is a classical old ortho. Nowadays, we have become obsolete. This slide has been put only to demonstrate because now we even our in common study of medicine, we are completely converted to the next slide. Completely, we gone to the newest model of the thermoplastic material. This is the leaflet orthosis, simple for when it is only mild dorsal paralysis. This is the molded AFO. This gives a medial lateral stability because it encompasses both medial and lateral malleoli. And the solid AFO, the difference between this AFO, the one and the same, but except for this, made of 3 mm, probably this is 5 to 6 mm, gives a larger stability to that. The spiral AFO with carbon and material assisted. I'm not able to manufacture this because the cost induced and very, very lightweighted AFO. The present AFOs are, we are using this AFO, not the conventional one, you see the previous one. So this AFO necessary to produce ankle stability, and these are the various conditions for which you are using it. Next time. These are the high-end ortho KFO, where the KFO two things are required in KFO, knee, ankle, foot orthosis. One component is stance face stability. The second component is the swing face mobility, ability flexion. So these are the high-end recent mechanical knee control orthosis, where stance control being provided with high-end ortho designs, knee joint designs. This is one among the latest knee joint where this is able to produce this kind of stability which is required during the stance and without interfering the swing face mobility. Next. What is this? There are so many types of knee joints. Ankles and knee joints available. And you initially saw the AFO. We have various functions. requiring the various types of things. This is to just to show you, depending upon the requirement, you have to fix the various types of knee joints available in the knee, ankle, foot orthosis. Next slide. What is this? This is one thing relevant to us in case of a paraplegia. Paraplegia where we require is a modified KFO. The three things are any kind of an orthosis has to stabilize three joints. It goes through. Here, ankle is stabilized by means of a neutral or mild dorsiflexion. It's a fixed ankle. We call this. Knee is locked in extension. So knee is stabilized, ankle is stabilized. And hip is actually what is called as the most important ligament is ligament of Bigelow. Probably, iliofemoral ligament. So what in doing by giving the anti 5-degree dorsiflexion of the ankle, the patient leans forwards, and because of the stabilized, patient goes back. So when it goes back, the ligament of Bigelow stabilizes the hips in extension. So this is one of the principles. Any joint has to stabilize all three joints. One is ankle is stabilized by the rigid 5-degree dorsiflexion, knee is long, hip is passively positioned in extension at the level of the, so this is a Scottish grey spot KFO used for paraplegia, where the patient has a mobility, where some kind of mobility is possible with the preserved L2, there is reflexor. So this is one of the orthos that should be aware of it. This is the design that we fabricate, that the patient has a potential for ambulation. Next. This one slide summarizes the in a paraplegia. What are the potential? This is what we do in our institute. We identify the level. We ask whether the patient has the potential or not. Up to T2, T10, only potential for ambulation. No, only standing, therapeutic standing we call. T12, again, the functional mobility starts because the hip hiking can be done, but still, this may not be the way it depends completely. Patient dependent ability of patients can contribute to that. L2, definitely patient has a hip flexor, starts mobility, healthy knee stability, and L4, L5 community ambulance. This is clearly one slide gives you what are the potential what the patient will be having with the depending upon the level of lesion. Next. This is a red markers alone, take it up, T2, T1, prescription orthosis, this is orthosis prescription. Orthosis bilateral KFO, the crutches or the walker used for just standing balance. The T12 maybe bilateral KFO, you are orthosis, hip guidance orthosis or reciprocal guide orthosis. These are the types of orthosis you can try. Next slide. Again, when it is L1, L2, hip flexion is possible, forward propulsion possible. Bilateral KFO with the forearm. But the moment the ankle is knee is stabilized, patient can walk with the AFO. And below L5, patient without an orthosis. So this gives an idea what probably the expectancy of walking, what are the expected guidance requirement of an orthosis for the patient. Next slide. So having said this, whether the patient's most important coming to the hip guidance orthosis, high level orthosis, whether the most requirement is whether they actually use it, because the cost of energy of ambulation is so huge. The most of the patients do not prefer to use it. That is, just want to give a difficulties at the cost of energy though. But the most important problem is patients, if you're going to say the patient you are not going to walk, they're not going to accept it. So the patients are provided all these opportunity for them to utilize them. Then, but however, in 5 years, the droppage of usage of those becomes very, very minimum or up to 23% only. So these are the statistics gives us the cost of energy of ambulation. So that's we also have to keep in mind, though the optic designs have been there with our recent advances as well. Thank you. Next page. What is this? Some bit of 3 slides on the cervical, this is spinal orthosis. This one slide tells you what is the amount of movement being provided by the various joint. For example, this is the flexion extension, this is the lateral bending, this is the axial rotation. So this slide gives you how much amount of the each joint are contributing for the motion. Next slide. And this single slide gives idea the various types of orthosis and is the nomenclature. how they are being utilized. So CO, cervical arthrosis, CTO, this halo, asomipres CTO, Milwaukee, cervical, thoracic, lumbospinal arthrosis. Okay, these are the various types that are being used. Next slide. This one other slide gives a clear degree of amount of immobilization and each of the arthrosis providing. Halo West, we think this is the most, you can see halo device, the only device which fixes from the head to pelvis. This is the one of the maximum providing list, halo device. You can see all other devices, none of the devices provides absolute immobilization. So this is one thing that should be aware of it. This is about the degree of immobilization being provided by the various spinal arthrosis. Next. This one single size simple is to say about the role of Philadelphia collar, thoracic, which is given thoracic extension as well. Next slide. Coming to a few slides on the processes. Most important thing, you should have the knowledge of end bearing processes and the proximal weight bearing. The limb has to transport the load from the limb to the prosthetic. So end bearing processes and proximal weight bearing process, probably be aware of it. Symes and thorough advantage, they are end bearing. They can directly transport the load to the process. There is no need to have a proximal weight bearing. But then when you come to the transtibial transfemoral, the patellar tendon is a zone where the weight being transmitted from the limb to the processes, while the transfemoral amputation, the ischial seat is the seat from where the weight being transmitted from the body to the ischium seat to the processes. This is the very basics of how the limb weight being transmitted. Next slide. So what are the components? PDB. So foot angle assembly is a proximal weight bearing, shank pitch, socket, and suspension. Next. Very basics of foot component, satch foot. Sometimes this might be a small sharp nose, something might be getting it. Foot orthotic types of prosthetic foots. So one is the satch foot, solid ankle. This is solid heel, bottom heel and cushion heel, multiple layers of rubber. Solid ankle, cushion heel. But this cannot walk barefoot on it. You have to put a shoe over it. So this is the simplest basic model of a satch foot. This is another foot which is well established those days. Jaipur PC Sethi is one of the renowned orthopedic surgeon and from Process designed this foot. What is the advantage of this foot? It's a 3-part vulcanized rubber clubbed together and made one single piece. Why? They customized to Indian domains. You want to walk barefoot, you want to walk on this water field. This should be fire resistant, water resistant, right? This is a very fundamental requirement of Indian culture. So this can do all sort of things. Can walk on the field. So they are in this Jaipur foot. That was 3-point vulcanized rubber. Next slide. Having said this, Oscar Pistorius is a man with Blade Runner, was running the Seoul Olympics with the bilateral below knee energy storing feet and competing with the normal population of a athletic population, and is actually a fight with the Olympic Association that doesn't want to participate in Paralympics and only participate in Olympics. So height of rehabilitation. So the prosthetic energy storing feet during stance phase, the force restores energy, and when it releases, that releases energy during swing phase. This is pushing now. So this height of rehabilitation. So if you don't have a limb below knee, don't bother. We have got this dynamic push-up given by the energy storing foot. Next slide. These are completion single axis foot. These are the various models giving only one axis of ankle in a plan. Dorsiflexion, plantarflexion. Next. Multi-axial foot. There is the multiflex joint from the endoline. It all provides the dorsiflexion, plantarflexion, inversion, eversion, but costly, expensive, less durable, but functional. So the more and more the foot nowadays, more the cost is the issue. The more and more we can spend to get the best the foot, everything can get. Next. The socket. The part that communicates from the stump to the prosthetic component. The socket, we should be there aware of it. This is designed in the case of transtibial processes is a triangular shape. You can see There are two important components that you have to remember as a student here. Weight bearing area, weight relieving area. There are two things. Where are the zones where weight can be transmitted in the processes to the lymphatic rate. So next slide. Next slide. Yeah, these are the blue zones are the zones where patients can transmit the load from the process to the process, the stump to the process. So the red zones are the zones where patients, the stocker has been relieved so that no pressure taken up. Next slide, will tell you what are the areas. These are the areas. So pressure tolerant. This is the patellar tendon. This is the name on which the maximum amount of 60% load is transferred from the limb to the processes. Patellar tendon bearing process. That's where we call the name of the processes. And the pre-tibial muscles can take the load. Gastrocnemius can take load. Poplite fossa can take the load. And medial flank. These are the areas, pressure tolerant areas. When they are, what are the areas? The meaning is any of these areas and the patient gets ulcer. That means these are zones where the pressure relief has not been properly been provided. So this is the basic thing you should be aware of it. Pressure relief area, pressure tolerant area. Next. The next socket to the endoskeletal or exoskeletal. Next line. This is the old conventional exoskeletal processes. Actually, we don't fabricate under the CM, CFMSL, Shushkin, where all the patients are being provided with endoskeletal processes in our institute. Even the transtibial and transfemoral all being fabricated by us. Still, there are old timers. What are the old timers? The patients coming with the 10th process or 15th process, way back. They stick on to these old processes. They want this particular model alone to be provided to them. They do not want the endoskeletal, but it has its own small advantage here. Again, can do in the field work can easily be fit with the Jaipur foot. But when it comes to endoskeletal processes, next is all the customized components are customized. This can be separate component. This is the connector component. This is a pylon component. This is a foot component, foot angle assembly. All separate are. What is the advantage of this? Any kind of a problem, each component can be removed and reset again. So discuss modular one, gives adjustments for deformities, corrections, some medial lateral angulations, anteroposterior angulations, rotation angulation, all this can be adjusted at this level. And pylon height can be adjusted by the various things, the height. This part alone, any of those particular part is damaged, we can replace it. Foot alone can be replaced. But the previous one, the whole unit has to be replaced. The conventional process cannot be, we have to redo the old one. The problem, anything comes with the advantages, also comes with the problem. You can't, because the closure unit is a foam. It cannot take during the rainy season, it is difficult for usage. But nowadays we are getting another over cover like what we do as a rainy cover, for which you can cover over these processes. But still, this is one of the disadvantages. It cannot be used in the during the rainy season also. So the whole thing has become wet and becomes a problem. Next line. Suspension. So you know the socket, you know the endothelial piece, you know the foot component, how the socket is suspended to the body. The basic simple model is supracondylar cuff. This is a very basic model. Second is a suction suspension that we'll see in the last line. These are the various suspension, how the process is attached to the body and is able to suspend. Next. Energy expenditure. Thank God with the lower, we in our patient, in our hospital also, all the patients are pre-prosthetic training and prosthetic training. All the patients, the tibial processes, amputation patients are allowed to walk on the treadmill near normal gait, so that to that extent, when they walk outside, you should really find difficulty which of the line is patient wearing the processes. So that is an objective and ideal prosthetic rehabilitation with regard to the transtibial. So we can see the very energy expenditure can be reduced to as low as 7% if you get a very good prosthetic. We call it a pre-prosthetic training, prosthetic designing. I'm not coming to those ones that's purely related to prosthetic. And post-prosthetic patient even should be able to walk near normal gait. Transtibial is never a problem. If you get a good stem, with regard to that, I always tell you as being an orthopedic surgeon, this is a very important opportunity I want to tell you. Please do not take an amputation surgery as a simple surgery. Please, I use the word please, because we are struggling with the stump if you do not give a good stump. Please take it a very important message. If you do not take any other message, no problem. This message, please take it up. Do not do a gelatin and do not, after doing gelatin, leave it alone. Don't put a skin graft. And don't do tight process, very short stump. Because you are giving a limb for him for life. And you're going to live with the life with that particular limb forever in life. So, this very important message I'm going to give it to you. Like any other important surgical procedure you practice, please practice this amputation surgery also. Clear procedure with the concept of what you are doing, where you are taking flap, how much taking flap, where is the cover, completely take this. It's a very, very important message because I am the person. If you want to show you, I will show you. I would thought of bringing the slides, but I do not want a negative picture here. There are so many stumps. We have a bad stump. We are regularly, this is called stump prosthetic interface. ஒரு கனெக்ஷன் இருக்கு இல்லையா ஸ்டம்புக்கும் ப்ராசஸ் சாக்கெட் இன்டர்ஃபேஸ் நீங்கள் மைக்ரோ மோஷன் கொடுத்துட்டே இருக்கும் இந்த மைக்ரோ மோஷன் கொடுக்கும்போது these are the பாயிண்ட்ஸ் ஆஃப் ஸ்மூத்தாக இல்லைன்னா the produces பாயிண்ட்ஸ் ஆஃப் ஸ்ட்ரெஸ் ஃப்ரீக்வெண்ட் பிரேக் டவுன் ஆகும் they live with ulcer repeated breakdown ulcer ஆகும் so this particular thing I want to highlight on this particular very important point because this is where we get this repeated breakdown of ulcer and please take this a very important message from me. Thank you. Next thing. This is a transfemoral ampullary. These are the characteristics of ideal transfemoral requestment. Next, we already know about the foot ampullary. We already know about the shank component. Only these two components will differ. Knee component. Next, mechanical knee joint or fluid control knee joint. Have an idea about what are the knee joints available here. Next, the simple caliper knee joint. Those days, this is a simple caliper knee joint with the drop lock. Very old patient, simply stabilizes during the knee, during stance phase. And when you want to sit down, you have to unlock the knee and sit down. This is a very basic knee. Very unconventional. Those days, these are the knees has been provided. Next stage during our PG day, this is a very common constant friction knee joint, which produces one speed, one cycle of speed only. Constant speed. They cannot vary the speed. This is the constant friction knee joint. Present day, polycentric knee joint. Next line. These two important knee joint which is being presently used is hydraulic and pneumatic. Next slide. It clearly says hydraulic is one of the best, very expensive. It is not being provided under CMC scheme because it is a cost about 3 to 4 lakhs. But we are providing at the pneumatic knee under the CMC scheme to all the patients. This hydraulic provides both swing phase and transverse control. But the pneumatic knee, next slide. This can produce the control during the swing phase alone, and we are using the polycentric knee joint, which gives a stance phase control, on which swing phase control of this pneumatic. This is the joint being provided under the scheme free of cost. Total cost about 1,75,000, given free of cost for this scheme. So this is the joint provided. These are the types of joints available. Next, iron joint. The cost I told you, the cost is the imagination. If you have the ability to do this is a microprocessors control knee, is able to identify the steps each and everything and is able to design, he was able to control the process. All become high tech and because of the AI dependent, they're able to define the various speed and various speed also is possible. They can intelligent knee. No longer you have to think about the changes on the walking speed. You can just walk faster, slower, what other things can be done. This is the this goes into more than lakhs, even 10 lakhs to 15 lakhs. Next slide. Socket. You talked about the socket of the triangular socket of the transtibial. You talk about the socket of the transfemoral. So only two things you have to remember here. Quadrilateral socket and ischial containment socket. These are two things you have to remember. This is a quadrilateral socket. Next slide. This is a quadrilateral socket. You can see where the ischial sheet will be the bearing. This is the lateral side. The wall is maintained. This is the top view. You see the top view will tell you most of the pictures are clear. Quadrilateral, 4 quadrilateral component. This is the ischial seat where the seat will sit. Ischium will sit and from there the weight will be transmitted to the processes. Ischium. So this is the quadrilateral socket. Next, ischial containment socket where the ischium will be inside the socket. Quadrilateral socket will be outside. So ischial containment is contained within the socket. NSNA, normal shape, normal alignment. CAD-CAM socket, adductor, trochanteric and control alignment method. You can see the next slide. You can see the picture will clearly. This is a quadrilateral. This one picture will tell you clearly what is quadrilateral, what is ischial containment. The quadrilateral, this is anteropost diameter will slow, but in case of ischial containment, the anteropost will wide and there's a larger support on the outer aspect and posterior aspect, and ischium will be inside the ischial containment side. So it gives you what is the advantage is short stem, weak quarters, weaker abductor mechanism. This ischial containment will better control of the processing. So this is a simple two things you have to remember. Two types of sockets. Quadrilateral socket, conventional, very commonly used. Other socket is a ischial containment socket. Next slide. Band. Oh, we are suspending it. We already talked about the band suspension in the tibial process. This comes from the transfemoral. This is a very conventional silation band. It's a band like a belt will be there, but the next mechanism is the suction mechanism. Next slide. This is nowadays being presently used, but all this costly, expensive. I don't provide this suspension to our patients because it's expensive. And as the patients, this is in the socket. This within the socket. This sleeve will be there. As the patient wears a stump, air is pushed out of the valve. This is the valve here. Air is pushed out of the valve. Then once the patient fully loaded it, and the negative pressure is created, the whole suction, the whole process is being suspended now. That is a very clear suction suspension system. It is being provided by the transfemoral and the transradial. So you heard about the socket component, you heard about the suspension mechanism, you heard about the knee joint, you heard about the sank piece, and you heard about the foot component. So that almost completes the one of the transfemoral as well as transradial. Next slide. Advantages of suction. It provides a greater, there is no need to have a band there. So greater freedom of movement, increased use of the remaining muscles, and decreased pistoning effect and less perspiration in the better corpus. These are the certain advantages of the using the suction method. Next slide. Again, the cost of energy consumption is usually very high because of the transfemoral, and we are not able to, even in transfemoral processes, we used to put the patient on the treadmill and give a very good amount of training for younger patients. But there are lower cross syndrome where the abdominal muscle is weak and with FFD, that is contractions, patients are still finding difficulty with that. So the gait velocity in a younger person is very, patients can do that, but then still older age patients will still have problems with it. Next slide. Thank you, Dr. Manibaran and the team for the wonderful effort, Dr. Paul sir, Dr. Pasuri sir, and the team for giving this opportunity.
Thank you so much, sir. On behalf of Institute of Orthopedic Surgery and Traumatology, Madras Medical College, kindly accept the mementos. Next, we start on with the quiz.
No one seems to be there in the hall. Everyone have. So we have come to the last leg of our gathering today. So anyone has to come inside, or shall we start? We'll start, sir. Okay. So lot of teaching and a lot of bombarding of knowledge. No, we have come to the final session. So even I have been in your position. Been correctly just 1 month before the exam, we'll get the seriousness to study, right? And all we try to attend all PG update programs, even if it goes on till 10 o'clock, we try to stay there. And that's when we think, 3 years of MS Ortho, we could have studied at least half an hour daily. Huh? Okay, so I am Dr. Sharath and I'm assistant professor in the Institute of Orthopedics and Traumatology. So my quiz topic is about nerve injuries, orthotics and prosthesis. Tirunavukarasu sir gave a very good talk on orthotics and prosthesis. So those who have attended, who are very attentive during the session could probably answer these questions. Okay, shall we go ahead? So the first question is identify this fracture.
The options are provided on the left side, and could you please raise hands according to the options? Who are choosing option A, B, C, or D? Accordingly, we will proceed. Accordingly, I'll be filtering the students and we proceed subsequent questions. Who all wants to go with C? Oh, it's a relatively easy question, right? So go to the next slide. So it's a coming to discussion part, it's a Holston-Lewis type of fracture. So as you all people know, it's a spiral fracture of distal humerus with radial displacement of the distal fragment. And what is the clinical importance here? The importance is these fractures are reported to have higher rate of radial nerve palsies when compared to other humeral shaft fractures. So especially when you're doing a close reduction of humeral shaft fractures and applying a POP, always you check for the distal neurovascular deficit. Any nerve entrapment or involvement is there, okay? Okay, so next question. So, any idea about this? What is a Martin-Gruber anastomosis? Option A, B, or C? B. Who all are telling B? Okay. Everyone wants to go with B? Any A, option A or C? Okay. Subhash, can you tell what is a Martin-Gruber anastomosis? You chose B, right? Okay, next slide. So, a Martin-Gruber anastomosis is nothing but it's a common anatomical variant involving a nerve connection between median and the ulnar nerve in the forearm. Specifically, it describes motor nerve fibers that leave the median nerve. Why I have highlighted this is we have to be wary of this, and especially when we are operating, we can inadvertently injure the aberrant branch. So, next question. So, can someone name this condition? And how do we treat this? We have 4 options here, A, B, C, and D. Who all go with option A? You? Okay, B. So first, what is this condition? Foot drop, right? Yes. Okay. So B, anyone wants to go with B? C? C. Okay. D? Wait, take an option. No, there's no negative marking or anything like NEET exam. D, yeah? D. Okay. So this is a foot drop. Who told option A? Okay, you come front. The correct answer is option A. It's a Brittle's procedure. I expected at least 2 or 3 people to raise hands for A. Okay. So what is a Brittle's procedure? Next slide. A Brittle's tendon transfer procedure is a specialized surgery designed to treat foot drop. So here what do we do? Most often resulting from peroneal nerve lesion or any other cause of muscle paralysis in the lower leg. The goal is to restore active dorsiflexion of the foot and allow patients to walk. Here we transfer the tibialis posterior tendon from the posterior compartment. We bring it to the anterior compartment. So in such a way that we give at least 3 or 4 by 5 power to the patient. Okay. So you have answered A, right? Okay. So next question, please. First choice will be given for the person who answered the previous question. So can you just identify or name the processes? A, B, C. I've deliberately kept the questions a bit hard. If you people would have been attentive in the previous session, you would have answered this. Sir actually spoke about all this. What's your name? By which college you're from? Which college? Okay. Very good. So you knew the previous question, huh? It's a Brittle's procedure, yeah? So anyone wants to give a try? Which option? Very good. It's a hybrid prosthetic hand. Your name? Which college? Very good. So next slide, please. Yes, it's a hybrid prosthetic arm. So what is the principle it works on? It works by combining myoelectric and body power technologies. So in such a way, it reduces the weight as well as cost of the processes. Okay, it's a hybrid arm. So both these people have answered one question. So next question will be both of you. Okay, you also come front. Can sit here. Next question, please. Can you identify this? What is this? Sir spoke about this also in the previous lecture. So this is used both in pediatric as well as adult population. Any guesses? Can you guess what is that? Looks like what? Looks like an orthotic device. Okay, what is that? It has an assembly from the hip, right? HKAFO. So what can that be? A. You want to go with A? You? A. He has selected A, and you can choose some other option. B. Or C or D? You want to go with B only? Okay. Next slide. The answer is B. It's a reciprocating gait orthosis. It is used in spinal pathologies with paraplegia to stand and walk. What is the specialty of this orthotic device? This is achieved by linking the hip joints of orthosis so that flexion of one joint causes extension of the other. In such a way, it will make the patient walk. Okay? Any other questions left? Okay, this is the tiebreaker. So he actually did not select an option. So it's a tiebreaker between both of you. Whoever wins this will, answers this will be declared the winner of the quiz. Okay. So name this. What is this? A, B, C. Either of you. No, both of you should not say the same. Who is going to answer first? You? What is the option? A, yeah? No, you can go ahead. Need not, if he says A, I should not say it's not like that. You can also A only, yeah? Yes. The answer is A only. It's a prosthetic device. This also was covered in the previous talk. So it's a polycentric knee prosthesis, also known as multi-axis knees, are designed to mimic the natural movement of human knee joint. So unlike a single axis knees, which operates only in a single pivot, the polycentric provides multiple axes, and the design is more suitable to provide a natural gait and improve stability during walking and other activities. So we can declare both of them as winners of the quiz. So let's give a good round of applause for them. So come forward. So please introduce yourself.
I'm Dr. Naveen Kumar, DNB postgraduate, final year, Vishnumur Orthopedic Hospital, Bangalore.
I'm Dr. Sri Krishna from CMC Vellore, final year PG.
So we request Professor Manimaran sir to give the cash, sir, to the winners. Thank you so much, sir. We congratulate the winners as well. Thank you. Thank you for your patience listening. Now Professor Manimaran sir will honor Sarath, Dr. Sarath. It is a very interesting session.
Hope today is a wonderful day for you. So tomorrow the sessions will start by 8:30. So tomorrow it will be packed with a lot of short cases. I want you to be at time. Thank you so much.
Consultant page ஒரு நிமிஷம்